Hello.
Hello.
Hello. We all know Dr. Sumit Kapadia. He is a gold medalist in MBBS. He has a national and international general publications. More than 30 articles has been published, and he is also a author of a book Vascular Diseases Simplified. He was a secretary of Gujarat Vascular Society and treasurer of Vascular Society of India. His special area of interest are dialysis, access, varicose veins, and vascular malformations. Dr. Sumit Kapadia.
Thank you so much for the kind introduction and a wonderful event for Baroda city, and good to be a part of Gimacon. As vascular surgeons, we deal with mainly three categories of diseases: arterial, venous, and others which may include lymphatics. I'll be mainly focusing on leg swelling and DVT and leg ulcers with special focus on diabetic foot, which is a common problem that we all will see in years to come. I'll start with a case or a real life incident of patients who were both treated, and we'll show you why a proper opinion and proper guidance makes a difference. So he's a 27-year-old male who developed sudden onset leg swelling, tightness and pain. The Doppler diagnosed as extensive iliofemoral DVT. He was treated with heparin and warfarin, which is the standard of treatment for all DVT patients. But 5 days of treatment, he still complains of very tight, heavy pain in the thigh and leg, almost to the extent that he is developing a compartment syndrome. Now, these patients, we do not know who will present in this way. He took different opinions, and different opinions would give real different opinions. So he was advised by fasciotomy by one of the doctors. One of the doctors also advised for a venous thrombectomy, means removal of the clots. Somebody like Ronaldo said, wait and watch. And somebody also advised for an IVC filter. Ultimately, what was done was the modern treatment of DVT, which is catheter-directed thrombolysis and angiojet thrombectomy. All of this thing was done under local anesthesia and was over within 2 hours. He had a 50% relief within 2 days and was discharged on the 4th day on oral anticoagulation. That's how the veins were. At the end of heparin, all blocked, the clots removed, thrombectomy and stenting done, and good blood flow restored. This is the clinical picture with a very tense, tight thigh and calf. So none of those opinions were wrong. They all were logically correct. But with the 5th opinion, he finally got a wonderful result, and that is the result at 7 days. A few concepts for DVT which we should know about is that heparin is an anticoagulant. The role of heparin is not dissolution of thrombosis, but it is to prevent propagation of thrombus, during which time the body's own fibrinolytic system takes care of the thrombus. All thrombolytic agents are the true agents which can cause dissolution of existing thrombus, and thrombectomy procedure, which can be done surgically as well as by minimal invasive methods, is the only method to surgically or interventionally remove the thrombus. And the current concepts do show that catheter-directed procedures are recommended, especially in young patients, because they offer rapid and more complete clearance of the thrombus. There is less chance of post-thrombotic leg. IVC filter is rarely required, and there is a syndrome which has become more popular now is May-Thurner syndrome, wherein the iliac vein is compressed by the right iliac artery. And in case a patient has a May-Thurner syndrome, then we do put in stents into the iliac veins. The role of stents for DVT and venous interventions has been increasing, and there have been a lot of published literature where endovascular interventions for acute as well as chronic DVT has been increasing world over. The reason is the removal of thrombus is a very important part for preservation of the valves, because whenever there is thrombus, it does end up damaging the valves, and that damage is permanent. So damaged valve will lead to reflux in the veins and gives rise to many of the symptoms of post-thrombotic limb. So there is a theory called as an open vein approach. Try to get the vein open as fast and as much as we can. I'll just show a few unusual diagnoses wherein patients were referred as to having DVT, but two very unusual diagnoses that we may see occasionally. That's a patient who had a DVT, but after the DVT resolved, we found that there was a large sarcoma in the thigh. So not all acute leg swellings are DVT. We may occasionally find such rare diagnosis too. And the other is a still more interesting patient where he had leg swelling pigmentation, but his CT angiography showed presence of an AV fistula at the popliteal artery level, with vascular malformations leading to so many veins inside the leg. He was treated by embolization and a covered stent placement. So we see that all these collaterals and everything have disappeared. So these are unusual cases which we sometimes encounter. I'll move on to the second scenario, which again is a common problem in our part of the country. A diabetic, hypertensive, elderly person, a doctor by profession. She did have mild pain on walking for 6 months, which was believed to be due to aging. Developed foot pain, thinking that it's a sprain. She asked her colleague to give her a POP slab, and the pain persisted. Because there was a slab applied, she couldn't really notice the condition of her leg. But as the pain increased and the POP slab was removed, what was found was this. Imagine a doctor and finding this after 4 days. It was such a bad scene for her. Again, multiple opinions, because there's always room for multiple opinions or different opinions. She was advised all of these practical things. Somebody said that the foot is already dead. Go in for a below knee amputation and go in for a best quality prosthesis. Someone says that below knee may not heal. Go in for an above knee amputation. Someone suggested at least take a vascular opinion, but somebody else suggested that gangrene is already set in. What will a vascular surgeon do? But well, she chose the third option and landed up with us. We did an angiography, angioplasty. The rest pain reduced. We waited for the gangrene to demarcate. She ultimately underwent a 4-foot amputation, followed by hyperbaric oxygen therapy. And saving a limb is a long journey. There is no shortcut to it. This was the picture of her angiography. The femoral artery was totally blocked, and that was responsible for her pain on walking for 6 months, which was not considered as a major symptom. She landed up with what is called as thromboembolism. The thrombus from there filled her leg arteries and gave rise to the acute onset pain. So we did an angioplasty stenting with a thromboaspiration, restoring some blood flow to the foot. And that's her entire journey over 90 days. From the earlier photograph that we showed, demarcated, ultimately underwent an amputation, healed, and then with the prosthesis, now back to work. So this was a very important and challenging case for all of us, emphasizing the need for timely diagnosis. Based on this, there are a few current concepts about diabetic foot which we all must know. The first is always considered ischemia as a cause of gangrene. Sometimes we attribute it to infection, but at least the cause of ischemia or reduced blood flow should be kept in mind. A timely vascular surgeon is often useful. These patients would have multi-level artery blockages wherein the results of angioplasty or bypass surgery does have a reasonable success rate of 70 to 80%, and that is just half of the story. The rest part of wound care is equally important. Proper debridement, antibiotics, the use of VAC therapy or negative pressure wound therapy, and the adjuvant use of hyperbaric oxygen does play a very vital role in trying to preserve foot amputations or leg amputations. There are various types of leg ulcers that we would encounter in our practice. Venous and ischemic ulcers combined or vascular cause would account for more than 80% of these ulcers. So the difference between the two also is very simple on clinical grounds. And venous ulcer will be near the medial or lateral malleolus with hyperpigmentation and thickened skin or lipodermatosclerosis, and there may or may not be visible veins. In contrast, an ischemic ulcer usually occurs on the toes, is quite painful. There would be some slough, the granulation is poor, the skin would be thin and shiny, and there would be absent pulse. So these are clinical differences which, as a clinician, identification is important for us. When it comes to diabetic foot, the International Group of Diabetic Foots has given a very clear statement that there is no such thing as a trivial lesion of the diabetic foot. Anything ranging from a small neuropathic ulcer to an infective gangrene, everything needs to be given attention. And ischemic diabetic foot is quite common. 40% of diabetic patients would develop foot problems, and similarly, the risk of symptomatic arterial disease is almost 4 times higher in diabetics as compared to non-diabetics. Of all the patients who have diabetic foot problems, 15 to 30% of them will have some element of ischemia, and when it comes to a major amputation, 90% of them will have an underlying cause as ischemia, the other important factor being spread of infection. So ischemia should be excluded in all patients with diabetic foot ulcers. And as vascular surgeons, our role is to try to do revascularization or re-establish blood flow wherever possible. And again, an interesting patient who had undergone a below-knee amputation 2 years ago, was not walking enough, but had chest pain. After an angio, was advised for a CABG. And after a CABG, this is the status at the vein harvest site. Now, at this level, she was advised to go for an amputation because it's ischemic. That's the angiography which showed an occlusion of the popliteal artery. We did a popliteal bypass and were able to save the limb here. So earlier it's done, the better. Our aim is to re-establish blood flow, try to preserve flow at least till the foot. Along with this, we should always remove the infected tissues. And as I mentioned earlier, the role of adjuvant methods is very, very important here too. A few of our revascularization surgeries which are commonly done, that's a femoropopliteal bypass with gangrene of heel. Earlier was considered as an indication for a below-knee amputation, but we have numerous patients where we've been able to save the limbs. Similarly, long segment bypasses from the femoral to the popliteal down to the tibial also has shown to give durable and good results. Localized diseases at the popliteal bifurcation may be suitable for a procedure called as popliteal endarterectomy. Again, this is a patient who had gangrene of the heel which recovered. Distal bypasses using vein is a preferred choice in these diabetic patients, and femoroperoneal bypass, that's an example of a bypass done from the femoral to the peroneal artery. We try to use vein wherever possible, and in case the quality or size of vein is not suitable, we use a graft above the knee, and below the knee for the distal bypass we use a vein. So bypasses can be done from any level to any level. Occasionally, for patients who have undergone repeat surgeries, we have to use synthetic grafts, not recommended, but if left with no choice, then yes. That's an example of a bypass done from femoral to the anterior tibial artery, and we can see that the status of the leg immediately after revascularization and debridement shows good bleeding. Again, this is a distal bypass done almost till the foot. Apart from bypasses, as Dr. Vijay showed in his talk, a number of these patients are also treated by multi-level angioplasty, and these are a couple of examples of those. That's another patient who had an angioplasty for the tibial vessels. Earlier, tibial vessels were considered to be untouchable area, but now we do angioplasty and bypasses as distal as the foot. That's a patient who has a stenosis at the dorsalis pedis artery, leading to toe gangrene. So angioplasty is possible even at this segment. A few words about the adjuvant therapy. This is the hyperbaric oxygen therapy which we have at Adicura. Very useful for non-healing ulcers, diabetic foot, and cancer-associated sinuses or non-healing wounds. A few examples of how adjuvant methods have helped us in limb salvage. Patients over 40 days show good improvement in granulation and healing, all thanks to a proper approach. Patients with large infected wounds, after revascularization and VAC therapy, they show a fairly good outcome. Again, patients are those who have undergone amputation of a couple of toes before coming to us and have been advised for below knee amputation, but many patients that we've been able to salvage, they are able to walk on their feet. This is our group practice of vascular surgeons at Adicura. So the take-home message is from my side. DVT, we must remember, occasionally may need an interventional treatment. If done in time, is very useful. Ischemia is very common in diabetic foot. We should try to seek vascular consultation early. Interventions, surgical or endovascular, have fairly acceptable results, and advanced wound care is an integral part of management of leg ulcers. Thank you so much.
Any question? Anybody?
Now the session is open for the question answer discussion. Any question?
To avoid post-lunch drowsiness, I request all to stand up and clap loudly for sir, please. Thank you, sir. It was lovely talk.
Thank you.
Now I welcome you down the stage for felicitation. I request Dr. Chetan Patel, sir, to felicitate with memento. Now I welcome Dr. Rupal Pachani, ma'am, on the stage for her next talk, Dietary Fads versus Facts, Simplifying the Oversimplified Food. And I request the chairperson to introduce ma'am.
Dr. Rupal Panchani. She is MD, DNB, endocrinologist, Adicure Hospitals. Her major achievement is gold medalist in MBBS in 2007, gold medal in endocrinology 2014, TYSA Young Scholar in Endocrinology 2013, and Best Resident Doctors in Sri Gangaram Hospital 2013. Her special interest on reproductive and adolescent endocrinology, obesity, menopause, and thyroid disorder. Now over to you, ma'am.
Thank you.
Before that, one important announcement. Mandala art workshop is going to start just outside this hall as a spouse activity. So those interested can join.
Thank you. Thank you, organizers. And I'm fortunate to be a part of this wonderful scientific fest. So, as I was requested by the scientific committee that in nowadays a common man as well as doctors are also bombarded with so much information on how to lose weight with various diets, and often there are some contradictory competing statements made on social platforms, and often these diets are endorsed by celebrities and they claim that they give a wonderful weight loss. So this basically talk is to give you a brief overview about the special diets which are doing the rounds in last decade in the market, and what would be the best diet program for your patients, and who would be the best candidate to have a diet therapy versus a pharmacotherapy versus a bariatric surgery. So starting with everybody's favorite, every celeb's favorite is keto diet. So this is basically a low carbohydrate, moderate protein, high fat rich diet. So if you are taking 2000 kilocalories, it translates to around 165 grams of protein, 40 grams of carbs and 75 grams of protein. So basically it covers 70-80% of the calorie intake comes from high fat. Now it is not new, it is since 1920 it has been used to treat refractory epilepsy in children, and where it reasonably works very well. If the children stick to that diet, it is shown that 50-70% of seizure remission occurs. But nowadays this is used for weight loss purpose in people who do not have seizure disorders, usually used in adults, and it has been used increasingly in PCOD, Alzheimer's disease, dementia and so many other chronic conditions. So the benefits of such diet is, as you see, that it is high fat, moderate protein, low carb. So initially patients would be very excited because normally a common person would think that while you are on diet, you cannot have malai paneer, or you cannot have egg burji, or you cannot have non-vegetarian high-fat food. But to their surprise, if they are given a keto diet, they will be allowed to have all these things. So initially there will be a lot of satiating effect. Definitely there will be reduced in appetite stimulating hormones because of the high fat content, and that is why how it reduces also their hunger, along with the ketosis which is induced by the use of high fat low carb, that also suppresses the appetite. And the increased caloric expenditure comes from the burning of the fat. So initially when you start a keto diet, after a week or so, there is ensuing ketosis. Body does not get enough carbohydrate, so it has to break down fat to generate ketone bodies, which the brain and the other organs use for the purpose of the energy. So that is how it promotes fat loss. But over a period of time, because the more and more when ketosis ensues in your body, many people would experience fatigue, low mood, irritability, constipation, headaches, brain fogging, dehydration, electrolyte disturbances, hyperuricemia is also noted. And if you are not good at correct choices of the substitutions of the carbohydrate, then you may also land up with the nutrition deficiencies. So substitutions are very important. So we really over here lack the high quality evidence, which we call randomized control trials, or large scale prospective studies or the cohort studies are required in such things before we say that they are safe and long-term efficacious. Short-term benefits are seen in people in terms of weight loss, and there is some improvement in the cholesterol level, but there is a warning that if your patient is having some cholesterol disturbances, your patient is having advanced diabetes, then and high or hypertension, these are not good candidates for keto diet. And as you know that in today's world, it's not uncommon to have even a 30-year-old male to come in your clinic with diabetes and dyslipidemia. Diabetes, dyslipidemia are almost like sisters. They do coexist. So you need to be very careful. When your patient comes to you and asks that, doctor, can I do keto diet? You need to be very careful that that person's metabolism should be thoroughly investigated, and then you see whether they are fit for it. Because in such diets, the quantity of the saturated fat would be high. And as you would have seen any medical guideline for any kind of diet, every guideline will say that there should be a restriction in the saturated fat. So in this particular diet, whichever fat you are choosing is very, very important. If you are using a healthy fat like extra virgin olive oil or avocado or healthy vegetable oils, then it is fine. So that knowledge has to be there. And there is also in question that when the people claim that they have lost weight with keto diet, is it actually the keto diet giving you a weight loss, or you are removing the refined carbs from your diet? Like you are not eating your sweets or cold drinks or laddus or the high number of chapatis that you are used to eat. Simply when you have removed that, your ketosis might not have even started. but you might experience a weight loss. That is because of removal of the refined carbs. So anybody who wants to have a more idea, these are some of the nice articles published in BMJ, Nature Reviews and JAMA. Now coming to the gluten-free diet, so it is basically a sole treatment for people who have celiac disease. 1 to 2% of population have celiac disease, and nowadays there is a new term called as NCGS, that is non-celiac gluten sensitivity. That people who do not have autoimmune response to gluten, but they do find good when they remove gluten from their diet. They find good bowel movements, their irritable bowel syndromes reduced. So gluten, as you know, is a naturally occurring substance in the whole grains like wheat, rye, barley, and as a contaminant in many sauces and flour, or in additives and fillers. So gluten, whenever somebody goes for a gluten-free diet, might experience better bowel, especially people who are undiagnosed cases of non-celiac gluten sensitivity. So, and there is some potential benefit in schizophrenia, atopy, fibromyalgia, endometriosis, PCOD and all. And people feel good energy and improved digestion and clear skin, probably because when they remove all the refined gluten-containing things like breads and maida and bakery from their diet, and when they resort to less processed whole foods like bajra, jowar, makai and all, that is why, so that may be the main reason. It's not the removal of the gluten that has given them a better skin or reduced acne and a weight loss. So, but what we have seen is in the market, there are equal number of gluten-free cakes, biscuits, all the bakery items available. Almost everything that you get, you also get in a gluten-free section. So the sections in these markets are bigger and bigger for gluten-free foods. So overeating the processed gluten-free foods are not going to give you a weight loss. So it might even in fact increase the fat content because you are compromising with the carbs. You don't know which carbs to be taken in place of gluten. Social impairment, restrictions, protein deficiency if you are not using the right substitution for gluten, right? And in many of the articles it is also said that at times some gluten is required as a prebiotic. It is good for your gut. So the bottom line is that the gluten-free is good for patients who are having NCGS, who are having chronic stomach problems. You may give it a try, but they need to be told about the basic substitutions. Without that basic substitution, they are likely to gorge on the gluten-free cakes and pastries and all, and they may not achieve any weight loss or any improvement in the quality of life. These are some of the nice articles where this was articles in JAMA and Journal of Gastroenterology, where they have said that in a long run, it is not that the gluten is bad, rather they have said that people who continued to have gluten had reduced cardiovascular risk factors. It is not that wheat is bad for your heart or your diabetes or your weight. Now coming to the intermittent fasting, out of all these diets which I discussed so far, this is probably the most culturally and religiously relatable diet to us, because we as Indians have been used to traditional fasting, religious fast and all. And by far this is probably the diet which has the maximum number of medical evidence in terms of more than 100 randomized controlled trials. So there are cycles of brief periods of fasting with either no food or very less calorie intake, and there are periods of unrestricted eating. These, as I said, they derive from the traditional fasting. The idea here is that if you continuously fast, your metabolism becomes very slow because the body also reduces its energy expenditure. But when you have intermittent fast and food, then the reduction in the metabolism may not be there. So there are several types of intermittent fasting, alternate day, whole day, time restricted, and these are some of the articles. So what they say that with intermittent fasting, any type of the ones which I showed, you do have a benefit in your weight loss, BMI, fat mass, cholesterol reduction, diabetes improvement, and there is improvement in the even blood pressure, heart rate, lethargy. But still we do not have very long trials for this kind of pattern of eating. And there are certain groups where you should refrain from advising these kind of diets, like patients with diabetes who are on hypoglycemic medicines, insulin and all, patients with eating disorders, use of medications which require food intake, and active growth stage like adolescent and pregnancy and breastfeeding is not the right time to go for these kind of diets. So the bottom line is that it does work, but it is not clear how long it is going to work. We need more cities over there. And people who are used to eating something or the other throughout the day, like it is called as grazing. The people with grazing behavior, they do very well with this kind of food because they are not allowed to eat anything in between. People who are used to late night eating, late night munching and snacking will do very well weight loss with this kind of diet. But you never know how long is going to be their adherence. So these are the other special diets you must have heard from your patient's mouth is paleo, Atkins, South Beach diet, clean eating, mind diet, and so on. So if the question comes in your mind that so far so many years have we been eating in the wrong way? I mean, all these looking at all these celebs endorsing keto diet and all, do you feel that what are we eating, roti, sabji, dal, chawal, is it a wrong thing? No, it's not wrong. Rather, we have every component of this diet in our traditional eating, be it a keto or intermittent or gluten-free. Everything was there in our traditional eating pattern in some or the other extent. But why today they may not work very well in all people is because of the excess of quantity. Addressing the stress is an issue. So stress, abnormal lifestyle, addictions, altered sleep pattern, that is something which has gone against our traditional way of eating. Otherwise, it is the old is still gold. And as I say that any particular diet if you pick up, ultimately your dietary adherence is going to reduce because of multiple things. Over a period of time, your reward centers will overpower you and they will make you eat. So as I show here that the red line is the energy intake and the gray one is the energy expenditure. So in the first few weeks, you will find good weight loss because your energy intake reduces and energy expenditure takes time to come down. So you have a huge negative deficit, which leads to a weight loss. But as you can see over a period of time, your hunger and your reward centers come over it. Similarly, there is a poor adherence with the physical exercise also. So what do we conclude from this maze of information? So who are the people who can go for these kind of diets? People who are relatively young, who have a BMI less than maybe 27, who are not very obese. Or the people who do not have serious comorbidities like advanced diabetes, coronary artery disease, chronic kidney disease, like they are the rest. And when is the best time? The best time is when your weight has just started to go up. BMI 25 to 30. People who have never control their diets, they do very well with the initial phase, and who are physically fit, who are willing to do regular exercise. And which diet? That you need to decide upon their social lifestyle, their preferences, their way of eating and everything. But there will be many more who will not fit into the group, like the people who have severe diabetes, people who are unfit to carry on any physical activity. So in an absence of physical activity, these diets are ultimately going to fail. People who have poor adherence, who are tired, frustrated, demotivated, using many diets, now they don't want to simply do any diet. People who are morbidly obese, who have lack of sustained weight loss, yo-yo phenomena, right? They do one diet, then they stop it, again do another diet. So this yo-yo phenomena is also not going to work. So these are the ones who may probably require bariatric surgery or a pharmacotherapy. Now when we talk about bariatric surgery, the first argument that comes to us is that मैं इतना खाती ही नहीं हूँ. હું એટલું ખાતી જ નથી, હું એક જ રોટલી ખાઉં છું. This is the first argument because that is a normal notion that you won't be able to eat. But it is beyond the amount of food that you eat that gives you a weight loss after bariatric surgery. So over here what is more important is if you compare between your diet and a bariatric surgery reduces the level of ghrelin and it increases the GLP, which is not the case in your diet-induced weight loss. And that is why over a period of time, your diet may not work very well, and the bariatric might help you to improve the set point of weight in your hypothalamus. So here you can see any form of bariatric surgery, if you do it at the right time and if it is accompanied with proper explanation and follow-up post-bariatric procedure, most of the bariatric surgeries will help you to sustain the lost weight even at the end of the 60 months, that is 5 years. This was a famous Stampede study in which they took 150 people with diabetes and they said that half of them went for a conventional medical therapy, diet, exercise and medicines. The other two went for a gastric bypass and sleeve gastrectomy. And what you can see at the end of 3 years is that in intensive medical management, almost 80% of the diabetes came back. And 65% had metabolic progression, which was not there in the case of bariatric surgery. So diets, they are easy to prescribe. Initially, they may be fun to do also, right? But they are difficult to maintain. And if you are on these kind of dietary therapies, your physical fitness, your motivation to continuously do exercise is very, very, very important, because physical exercise is the only thing which helps you to gain lean body mass. Any other form of weight loss will make you lose lean body mass along with the fat mass. There is no such diet that claims that you will lose only fat. Almost every diet-induced weight loss will make you lose some muscle as well. Medicines, we have so many new medicines coming up, Rebelsus, Wegovy, Mounjaro and all. These all are GLPs, right? So these GLPs, they work very well, but they are very expensive. Now, if you do a 3-year GLP therapy, it might help you to achieve some 15-20% of weight loss. But the cost of a 3-year GLP would be equal to cost of doing a gastric bypass. And GLP, once you stop it, maybe in 6 months or so, if the patients are not sticking to physical exercise and all, your weight loss which is there will gradually go back to its usual weight, which might not be the case in the bariatric. However, the latest GLP analogs and all are very good for heart. So when your patient is not surgically fit enough to undergo a bariatric surgery, these drugs are a must try, because it also gives them protection to cardiovascular health. Bariatric surgery, at the initial, it is difficult for even the physician to convince the patient, and for patients it is difficult to accept that now everything has failed and they are supposed to go for it. So that is why the right time of advising a bariatric surgery is very important. Most of the time people resort to it when they are obviously tired and demotivated and frustrated of doing everything, and they're already having more than 2 or 3 comorbidities related to morbid obesity. That is when they go for bariatric surgery, but it should not be the case. It should change. The right time, right procedure is very important, and choosing the right patient. So long-term results, as we saw here, they are very promising when it comes to bariatric surgery. So to summarize, the bottom line is, as I've shown here in the pictures, that young, fit people with a very high index of motivation and well-informed, if a good nutritionist is prescribing diets such as keto diet or a gluten-free or a intermittent fasting, in a short-term period, it is good. But if you are feeling that your patient is not fitting into this box, then it is better to either go for the long-term results like bariatric or the pharmacotherapy. People with requiring long-term weight loss, higher BMIs, diabetic, with or without other complications, you may give a try of pharmacotherapy. But in a long run, people with overweight and morbid obesity, or BMI more than 30, with multiple complications, advanced diabetes, and physical inactivity like osteoarthritis and all, who are not able to even move, the best thing will work is a bariatric surgery for them. Thank you so much.
Any questions?
Anyone from the audience who wants to ask a question? I am surprised because this was a talk where I would expect a couple of questions from the audience. I think Rupal did a very fine job in describing
Thank you.
the common practices in diet. Thank you, Dr. Rupal.
Soldiers, wake up, stand up, clap loudly. Thank you, Dr. Rupal, for your knowledge-sharing talk. Now I welcome you down the stage for the felicitation. I request Dr. Hitesh Vasawa to present the memento to Dr. Rupal. Now I welcome Dr. Pankaj Khandelwal sir on the stage for his talk on weight management, a surgical approach. And I request the chairperson to introduce him.
Good afternoon, Dr. Pankaj Bhai. Dr. Pankaj Khandelwal is a very senior laparoscopic and bariatric surgeon at Adikura, and I think he doesn't require any introduction. Most of the consultants and general practitioners of Baroda are quite known to him, and he also knows most of them. He has been practicing laparoscopic surgery for more than 25 years now, and I think he was one of the first to start bariatric surgery in Baroda, and subsequently there are a lot of centers for that. And Dr. Pankaj Bhai is also national and state faculty, has conducted many workshops. Over to you, Dr. Pankaj Bhai.
Thank you, Samir, for introduction. Good afternoon, everybody. Now, over the last 20 years, we have seen that the obesity problem in India has gone up significantly. And in the last 10 years, we have also seen that the popularity of bariatric surgery has also simultaneously improved. Now, during this period, there has been a significant fear among the doctors as well as the patients about undergoing bariatric surgery. So we find that a lot of bariatric endoscopic procedures have come up. And over the last few years, a few of them have been significantly advertised as well. But if we see the actual scenario, what happens when a person who is obese in this country, what happens to him? So his relatives tell him that you are at fault because you overeat and you don't exercise. The trainer in the gym, the nutritionist, and doctors. Everybody tells the patient that you are at fault, and because of your not doing the things right, the problem occurs. But what does modern research tells us? It tells us that the body seeks a stable fat mass, and there is basically a set point in the brain which sets your body fat mass. So it's something like an air conditioner. So when you set up the air conditioner to 27, the temperature fluctuates between 25 and 29. Similarly, the body fat mass also fluctuates. But this set point gets disturbed by multiple things, like abnormal dietary factors, unhealthy muscles, sleep deprivation, stress, altered circadian rhythms, being on medications, and different chemicals which cause endocrine disruption as well as are obesogenic. Now, all these factors basically increase the set point. So what it basically means is that obesity is not a metabolic disease, it's multifactorial, and bariatric surgery is actually just not something which reduces your food intake, but it is a metabolic surgery which causes a lot of change in the body. Now, whenever we talk about weight management, there are two aspects to it. One is losing weight, and the second is maintaining the weight loss. Now, most of the things which are available, whether it is your dieting or the bariatric endoscopic procedures, all of them give good weight loss. But when it comes to really maintaining, there the problem comes. And all lifestyle modifications we talk about, they have to be sustained either for a very long time or lifetime. Otherwise, the weight is going to come back. So nowadays what we actually need to manage weight is basically a multidisciplinary center. And in this you would have right from lifestyle modifications to an endocrinologist giving pharmacotherapy to a bariatric endoscopist to a bariatric surgeon. So we have bariatric surgeon, endocrinologist, endoscopist, and a good support team of a nutritionist, counselor, physiotherapist, as well as a psychologist. Now, there are two terms which we very commonly use. One is the percentage total body weight loss and percentage of excess weight loss whenever we compare different modalities for weight reduction. So coming to the endoscopic bariatric therapy, over the last 20 years, we have seen a large number of devices, right from gastric restriction by space-occupying devices to stapling devices, malabsorption, as well as other mechanisms. Now, these space-occupying devices are basically different types of balloons which are placed inside the stomach. They come in different shapes and sizes. Even like one of them, if you can see here, has one small balloon going into the duodenum. But basically what they do is they reduce the food intake by taking up the space inside the stomach. The other is the stapling devices which have come up. This is the post procedure in which the fundus of the stomach is stapled. And there is the endoscopic sleeve gastroplasty in which you have a long tube formed of the stomach by stapling. Multiple malabsorption devices have come. You can see different varieties. They start from the duodenum to the jejunum, start from the OG junction up to the jejunum. and magnetic anastomotic devices, but none of these have actually made a significant impact because either they have been associated with significant complications or with a very small amount of weight loss. Now this is a very interesting as well as a funny device in which a PEG tube is placed inside the stomach. So the patient goes, has whatever he wants to eat. 20 minutes after that goes to the washroom and empties the stomach by opening up the PEG tube. So this is something which is very funny and we would find it to be, it's something not acceptable. But interestingly, large number of studies have been done with this particular device, and they show an almost 15% of total body weight loss at the end of 1 year and 20% at the end of 2 years. So though funny, but it has its results. Now, two very common procedures which in the last 2 years have been advertised significantly in India. One is the swallow pill, which is basically a variant of the intragastric balloon. And second is the endoscopic sleeve gastrectomy. They have been advertised a lot. So I would just like to talk a little bit about what results we see with them. So the swallow pill is basically a variant of intragastric balloon. You can see different varieties here. Now, when you see the intragastric balloons, they are mostly introduced by endoscopy as well as removed by endoscopy. The only difference with the ellipse balloon from Allurion, which is basically the swallow pill, is that it is to be swallowed and it gets spontaneously dissolved in 4 months and it is excreted out. So this is the shape of the balloon, nothing different from the rest of them. And a few studies which have been conducted with this balloon basically show that you have a 12.8% total body weight loss over 6 months. At the end of 1 year, you have about 10.9. We don't have any other long-term data beyond that. This is another study which also shows a 12.2% weight loss, but you can see that it is also associated with a significant number of side effects like abdominal pain, vomiting, diarrhea, and some serious complications like small bowel obstruction. So these procedures are not very good, and that's what we have also seen in our practice. Like these are 3 other balloons which have been US FDA approved, and the results very similar. Now, the biggest problem with the intragastric balloon is that the results are not good over long term. Like this particular study shows that at the end of 1 year, there was only a 2.8 kg weight loss, an average weight loss for most of the patients. And that's what our experience has been. We have used about 15 to 20 patients. We have used the balloons to find that after a year, most of the patients, the weight comes back. Now, looking over the stapling devices, endoscopic sleeve gastroplasty, again, that has been there only for the last 9 years, initially introduced in 2013, and it has been marketed as an endoscopic transoral procedure. It's basically an endoscopic suturing device, which sutures takes full layer thickness of the stomach to form a tube of the stomach, and the rest of the stomach, the fundus and all is isolated. Now, what do we see? The weight results here is again 17% approximately at the end of 1.5 years. Now, again, when you try to look for long-term data here, there isn't much of long-term data after 2 years available on the endoscopic sleeve as well. Now, when we compare lifestyle modifications versus the endoscopic sleeve, we find that at 12 months, the endoscopic sleeve is giving 20%, while the lifestyle modification 14%. When you compare to the intragastric balloon, we can see that this endoscopic sleeve maintains a 17% weight loss, while the intragastric balloon, the weight loss goes down significantly. Now, when you are comparing the endoscopic sleeve to the laparoscopic sleeve, we find that the results of the laparoscopic sleeve are far more superior as compared to the endoscopic sleeve. Now, one of the ways the endoscopic sleeve has been marketed is that it's a procedure which is fairly safe and does not have complications. But all these studies and meta-analysis point out that there is practically no difference in the safety profile between these two procedures. And one major limitation is that we do not have more than 2-year follow-up, so we don't know in the long term how this is going to work. On the other hand, you have bariatric surgery which has been there for more than 50 years, and you have got large number of studies which have been followed up over long term, which have shown that the durability of the surgery is very good. Now, earlier what used to happen was we would always recommend surgery to patients who had a BMI of more than 40 or comorbid conditions with BMI more than 35 or 30 to 35 with uncontrolled diabetes or metabolic syndrome. Now, 2022 October, these guidelines have been changed, and you have any patient above the BMI of 35 is eligible for a bariatric surgery. Anybody with diabetes and a BMI more than 30 is eligible for that. And anybody who has tried a lot to lose weight. Now this used to be a very common problem. Patient would come કે સાહેબ 2 વર્ષથી બધું try કર્યું પણ વજન ઉતરતું જ નથી. And then you would tell them that your BMI is only 32 and I cannot operate on you. So he would say कि तो હું 35 BMI કરીને આવો તો તમે operate કરી આપશો. So this type of a issue used to come very often. So now if somebody has tried all modalities and still not able to lose weight, these category of patients can be taken up for surgery. Now what we normally see is patients who have joint pains, patients who are going to go for joint replacement, backache, infertility, uncontrolled diabetes, severe obstructive sleep apnea, multiple comorbidities, significantly reduced mobility. They are not even able to move comfortably inside their own houses, or for cosmetic reasons. These are the common reasons why patients come to us. Now different options, all of these surgeries are laparoscopic. So most of these patients would be discharged on the second or the third day after the surgery, and they would be able to go back to normal functioning within a week to 10 days. Now, which are the recommended surgeries? If we look at the ASMBS guidelines 2020, Roux-en-Y gastric bypass, sleeve gastrectomy, gastric banding, and the BPD. Now, gastric banding for all practical purposes has been out now because it doesn't give very good long-term results, and BPD has gone down in favor because it's associated with a large number of complications. So the commonest surgeries we still have are the sleeve gastrectomy and the Roux-en-Y gastric bypass. The sleeve gastrectomy, in which we remove a part of the significant part of the stomach. So what's left behind is basically an 100 ml pouch. So you see also a significant reduction in the ghrelin levels. The GLP-1 levels also go up. So following sleeve gastrectomy, we tend to see good weight loss. One of the major issues with the sleeve gastrectomy is that quite a few patients will have reflux symptoms. Most of them are very well controlled with proton pump inhibitors. Very few would require anything more than that. The the surgery which is considered as the gold standard and has been the oldest surgery, more than 50 years now, the gastric bypass. In this, we tend to remove this part of the stomach, make a small pouch, and then about 50 to 100 centimeters from the DJ, we would transect the jejunum and anastomose it to the stomach here. So you have this area where there are no digestive enzymes mixing into the food which is eaten. So you have restriction, simultaneously you also have malabsorption, and both of them give rise to a good weight loss. Very strong metabolic effect, very good surgery, and it's a good surgery for patients who have hiatus hernia or reflux problem. But the problem, the other side of it, the disadvantages are, it is associated with a large number of minor issues which do continue for a long time. Marginal ulcers, internal hernia, postprandial hypoglycemia, and that is the reason we see that quite a few people in the US don't want this surgery to be done nowadays. One surgery which remained controversial for a very long time, it has been, rather Indians have been among the surgeons who have popularized this surgery throughout the world, and that's the mini gastric bypass. And it's a little easier than a gastric bypass. It gives good weight loss and a good morbidity resolution. Now here what we tend to do is have a long pouch of the stomach, and the Roux-en-Y limb is not taken, but directly about 150 to 200 centimeters from the DJ, the jejunum is anastomosed to the stomach pouch. It's associated with a high malnutrition as well as a risk of bile reflux. So this surgery is also a surgery which is becoming popular. Now, if we see among the commonest surgeries performed in the world, the sleeve gastrectomy is the most commonest. And this is the 2020 data from US. You can see that the sleeve from 2011 has gone to almost 60% of the cases, that is approximately 200,000 cases. Out of that, the Roux-en-Y gastric bypass from a little less than 40 has gone down to about 20. In between, US had a lot of revisions, which we can see here, and that's because they did a lot of bandings, and a good number of the bands required revision surgeries. So band, that's why, is not very popular nowadays. Now, whenever we talk about any bariatric surgery, it's basically a balance between the amount of weight loss, the issue of weight regain versus the malnutrition. So the stronger the procedure, more will be the weight loss, but correspondingly more will be the malnutrition issues. So when you see the whole spectrum of surgery, the gastric band, which has the minimum weight loss, has minimum malnutrition problem, while the BPD has the maximum malnutrition problem. Good resolution of comorbidities can be seen. And when we see results over the long term, like a surgery like sleeve from 149 kg, a 18-year-old boy to 96, from 181 to 107, 141 to 78, from 81 to 59, this was more for cosmesis. A gastric bypass 117 down to 75 with complete resolution of the diabetes, 165 to 105, 141 to 84, and 139 to 77. Now, factors which make a difference among different patients in the weight loss, one of the major factors is age. Younger the patient, more will be the weight loss. The second is how many of these patients actually have a change in the lifestyle. So whosoever will have a change in the lifestyle will be able to have a much more better weight loss and will be able to sustain that better. Now, this is one very interesting case. This is a non-obese. I normally don't operate on non-obese diabetics, but this was one of those cases. Patient had a 44-year-old lady with 23 years of diabetes. She was on all types of diabetic medications, hypersensitivity to insulin, so she couldn't take insulin, metformin toxicity, and in spite of that, her HbA1c was remaining at about 11.9. She was also an hypertensive for 15 years, taking multiple antihypertensives, but in spite of that, uncontrolled blood pressures 200 by 118. Simultaneously, she had undergone an angioplasty, aneurysm, coiling, and had a diabetic foot, polyneuritis, past history of hemiparesis, neurogenic bladder, and to make matters worse, she developed a very bad diabetic retinopathy with loss of vision in the left eye, and the right eye vision completely was reduced. So the retinal surgeon advised her to get the diabetes and the blood pressure under control. She went down to different doctors and was then advised a metabolic surgery. Now, this being a non-obese metabolic surgery, I didn't want to do our standard surgeries, so I opted for the different surgery which is called as a sleeve with DJB. Now, in this surgery, what we do is we do a sleeve first, and then we take a loop of the jejunum about 100 centimeters from the DJ. After transection of the duodenum at the pylorus, an anastomosis is done here. So the bile will not go back into the stomach, it will go back into the system. And this surgery has shown very good results with non-obese metabolic patients. Now, this patient was discharged on the 3rd day, drain removed on the 7th day. After a year, she didn't have a significant weight loss. The weight reduced from 64 to 57 kg, but her blood pressure has come down to normal, 130 by 80, HbA1c at 6.1, no antihypertensive tablets, just one oral anti-diabetic medication she was on. Then she subsequently underwent surgery for the retina, and her vision of the eye, which was reduced, improved significantly, and the other eye also she recovered some vision. So these surgeries, very rare to see such type of cases, but a very good extraordinary result seen with this metabolic surgery. Now the issue comes that you have a huge plethora of things going on, so what do you select and where do you select what? So if you wanted 10% weight loss or less than 10%, lifestyle modifications would work most of the time. Intragastric balloon for 10 to 12% weight loss, but knowing that it's not going to be there for a long period. Endoscopic sleeve gastrectomy for 16 to 20%. A sleeve gastrectomy if you're looking for 25 to 30% weight loss. A Roux Y gastric bypass for 30 to 35% weight loss. So if we look overall, surgery results are pretty good. It's fairly safe. Problem of weight regain is there, but in few cases. And one of the commonest reasons why some patients refuse surgery is that the weight comes back. Now, one lady came to me, referred for a weight reduction surgery at 130 kg, didn't get it done from US. She comes back after 3 years at 160 and gets the surgery done. Now, what happens is when you operate at 160, the weight loss stops at 100. When you operate at 130, it goes down up to 80, 85. So the level of weight loss a patient is going to get is much lesser. So to summarize, obesity is a metabolic disease. We need to treat it the same way as we treat diabetes, cancer, etc. Treatment options depend on the severity and what our targets are. But whenever you have comorbidities, you should always prefer bariatric surgery. And the role of these newer techniques is not yet clear. Thank you.
Thank you, sir. Any question? Anybody?
Anyone from the audience? I think we can proceed.
I know we are making you stand up every time, but this is a new strategy to give respect to all our speakers. So kindly stand up and clap loudly for Pankaj Khandelwal, sir. Now I welcome you down the stage for felicitation. I request Dr. Samir Contractor, sir, with memento. I also welcome all the chairperson down the stage for felicitation. I request Dr. Kailash Parikh ma'am, Dr. Deepak Mehta sir, and Dr. Mahesh Bhatt sir to present memento to all our chairpersons. And to chair the next session, I invite Dr. Samir Shah sir and Dr. Neeraj Chawda sir on the stage. Dr. Samir Shah sir is a practicing pediatrician, a great man in the field of pediatrics and adolescents, a secret superstar. Samir Shah sir is locally and nationally too. Dr. Neeraj Chawda sir is a consultant physician and chairman of Scientific Committee Gimacon 2022, who is also a man behind entire great academics of Gimacon 2022. Now I welcome Dr. Deepak Jumani sir on the stage for BJ Vasa oration, and I request chairperson to introduce sir.
Hello. This is one of the most important topic and also the most important scientific session, that is the BJ Vasa oration of IMA Vadodara. And the topic, that is the what we usually reluctant to talk, but it's a necessity for the hour. And that is the male sexual disorder and enigma, on which we having a none other than the Indian most popular speaker on this topic, that is the Dr. Deepak Jumani. Regarding his short CV, because he has a so wide CV, so I am giving a brief of that. He is honorary assistant professor of the Sir Jaji Hospital and Government Medical College and Mumbai Police Hospital, fellow of the Regenerative Clinical Medicine, diplomat American Board Certified Clinical Sexologist, fellow of the American College of the Sexology, a certified sex therapist, and course director and mentor of the Fellowship in Clinical Sexology. He is co-chairman in IMA's Initiative for the Sexual Health and Cybercrime Intervention Officer also of Government India. He is author of a bestseller, Sex Has No Expiry Date. So, sir, stage is of yours. Thank you.
Thank you, Samir Bhai, for that sexy introduction. अच्छा वक्त ज़रूर आता है, men do get erections, पर कम वक्त पे नहीं आता. वो पल भी आया तो कुछ पल के लिए, सोचा उस पल को रोक लूं और पल के लिए, पर वो पल न रुका एक और पल के लिए. This is the state of affairs we see in our day-to-day life, in our practice. At the outset, I thank IMA Vadodara and Gujarat IMA. I also thank Mitesh Bhai, Samir, Neeraj, Pragnesh, Mehul, Anjali for making me feel very special by inviting me here. And I also am honored to deliver this Dr. Bhupendra Vasa oration. I'm aware of him as a Chief Medical Officer for Gujarat Refinery, a wonderful, humane human being who was very philanthropic. I am aware of his children. One of them is a pediatrician, nutritionist, and a neonatologist, and the other daughter is a pathologist. Around the world, people love. They sing for love, they dance for love, they write poems, they write legends, they fight for love, they kill for love. In fact, we all sitting here are all victims of love. We are all born out of love and sex, but still we don't talk about it. The topic today, which I'm going to stress my expertise on, is male sexual disorders. Is it an enigma? Let us see. I don't think it is, and it can never be. But let me prove it to you.
Gurur Brahma, Gurur Vishnu, Gurur Devo Maheshwara, Gurur Sakshat Parabrahma, Tasmai Shri Guruve Namaha, Tasmai Shri Guruve Namaha, Tasmai Shri Guruve Namaha.
I thank my teachers, Dr. O.P. Kapoor, Dr. Prakash Kothari, and Dr. Shashank Joshi, and I beseech them to bless me always. I have some disclosures. I am not from Congress, Shiv Sena, BJP or Aam Aadmi Party. I am not a follower of Asharam Bapu, Ramdev Baba or Radhe Ma. I am not married to Indrani Mukherjee. I am an Indian Medical Associationite and am passionate to educate the masses on ethical science of sexuality. Mitro, look, our Prime Minister's hands are down and he had no other choice but to offer GST. And then he told me, Deepak, you also. So look, my hands are up and I also shall offer my GST, and my GST to all of you is great sex therapy. Is sex a secret? Who doesn't know what is sex? I think even a 12-year-old guy knows what is sex. It's not a secret. What we should understand that it is not a secret, but it is a sacred soul of our life. Intimacy is ageless, but to ignite intimacy, we need to have strategies, proper strategies of our mind and body for optimum sexual pleasures. Sex is created by God and it's called very good. But so why are we scared, or why are we not following the good path? It's an illustration of God's relationship to his people. Sexual purity is a special area to watch out and be diligent in. Sexual behavior, friends, today has been twisted, torn, but sex itself is not ruined by the fall. Sex is to be enjoyed without guilt and shame. And sex is to be used, not abused. The central element in the normal life of human beings is what? Leave aside human beings. If we look at animals or vegetable kingdom, what we all find at the core of everything, what is a plant doing in its essence? Its whole energy is directed towards producing seeds. Its entire being is occupied with forming new seeds. What is the bird doing? What is the animal doing? Everybody is trying to produce themselves similarly. So if we look closely into nature, we find that there is only one wholehearted process going on. It is one of the continuous creation of procreation, of continuous resurrection of life in newer and newer forms. The same is the case in human beings. We have named this endeavor of constant procreation in humans as sex. This labeling has given a kind of condemnatory feeling in humans about it. Nevertheless, in humans also, a constant effort to procreate life goes on. Today, every wife is a mistress for a husband. Miss for 1 hour and the stress for the rest 23 hours. There is total, absolute, persistent disregard towards the woman's satisfaction. And what we are discussing today, enigma. What does enigma mean? It means something hard to understand or explain, or an inscrutable or a mysterious person, an obscure speech or writing. It's absolutely wrong. It's not an enigma. Today there is a sexual health tsunami across the globe. Every male or female today have bedroom woes. 40% of men above the age of 40 are not satisfied with their sex lives. A beautiful survey done said 62% of women admitted that they are not satisfied with their sex lives. Impotence has been the common cause of divorces in India. 50% of married couples across the most developed country like Japan are living sexless. So it's a huge problem to the individual, to the partner, and of course there is a dent in the relationships. So when we look at patients who come to us, what do we do? How do we go about it? There are 4 cardinal events which happen during the sexual act. In males, it begins with the desire. So men can have low desire, high desire, no desire. Erection, he can have no erections, dysfunction, penetration disorders, ejaculatory disorders, and orgasmic disorders. So these are 4 events which we need to focus on to prove that whether still it is an enigma or a confusion or not understood well. A beautiful study which we did at KEM Hospital, me and Dr. Prakash Kotar, 56,000 patients, all were diabetics between the age of 32 to 70, and all of them men had erectile dysfunction, early ejaculation, and hypoactive sexual desire disorders, and females had low desire, and depression was seen as the most common problem in every diabetic woman. Across the globe, India and China are having maximum cases of diabetes. In fact, I call China and India, or Chindia, are the diabetes capital of the world. And erectile dysfunction is the commonest complications of diabetes in men. So Chindia are the erectile dysfunction capital of the world. If you define erectile dysfunction according to the APA 2016, it is inability to attain or sustain erection for a satisfying intercourse. It has to be there for minimum 6 months, and there has to be interpersonal clinically significant distress and not due to any mental disorder. If we look at the causes of it, it can be psychogenic, which is the most common, vasculogenic, neurogenic, hormonogenic, drug-induced, and genetic. But whatever may be, it may be organic, but there is always some psychogenic component in all them. Genetic, because they found a special Simon loci associated with erectile dysfunctions. When we look at the dynamics of erection, it's threefold. First, it's neurologically mediated increase in the penile arterial inflow. Then there is a relaxation of the corpora cavernosa smooth muscles. And then there's a restriction of venous outflow, which maintains the hardness or the rigidity in the penis. So everything boils down to blood flow in the penile vasculature. Whenever there is reduction in the blood flow or some problem with the blood flow, it's erectile dysfunction. So I call erectile dysfunction as nothing but penile attack or penile angina. And the 4 deadly quadrant patients who are diabetics, obese, hypertensive, dyslip. Trust me, all of them have erectile dysfunctions. Now let me give you a little deeper perspective. Sex can be a wonderful thing at any age, but when you look at the corpora cavernosa smooth muscle and the endothelium, every normal endothelium produces endothelial nitric oxide synthetase, which enters or potentiates the nitric oxide, which is the main chemical signaling molecule or the miracle molecule or the molecule which initiates the whole erectogenic process, enters the corpora cavernosa smooth muscles, converts guanosine triphosphates into cyclic guanosine monophosphate. This cyclic guanosine monophosphate relaxes the smooth muscle and allows the blood to flow inside the penis, and man gets erection. But sadly, this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme called phosphodiesterase 5 or PDE5. So if you look at what current therapies we are giving to our patients, we are not doing anything with the endothelium, we are not doing anything for the nitric oxide, we are not doing anything to improve the cyclic GMP. All we have is PDE5 inhibitors in the form of sildenafil, tadalafil, sildenafil, vardenafil, and now new kid in the block, avanafil. So when you look at hyperglycemia, increased advanced glycated end products and oxidative stress leads to cavernosal endothelial dysfunction, structural and functional changes happen in the penis, and man gets erectile dysfunction. So there is definitely a link between erectile dysfunction and endothelial dysfunction. Because if the endothelium gets hampered, less endothelial nitric oxide comes in, less nitric oxide is formed. So erectile dysfunction is nothing else but endothelial dysfunction. So beautifully told by my Professor Paul Von Hort from Mayo Clinic, you are only as old as your endothelium. Why should we be worried about erections? What is so important about it at the age of 40, 45 or maybe a little earlier? Because today erectile dysfunction has been proven to be the earliest marker of myocardial ischemia. In fact, there is a relationship of erectile dysfunction which is nothing but subclinical cardiovascular disease proven beyond doubt. When we look at the patients who had a lot of cardiovascular risk factors or apparent clinical disease, throughout these patients had erectile dysfunctions. So erectile dysfunction precedes the severity of coronary artery disease by a period of around 3 to 5 years in most of these patients. Here is the clinician smartness or acumen which is tested. If he is asking a symptom of erectile dysfunction in his patients much before the metabolic syndrome sets in those patients who have family history of erectile or cardiovascular disease, diabetes, hypertension, dyslipidemia, etc., he is doing a great service to him. Because once he diagnoses erectile dysfunction, say at the age of 28, he counsels him, he advises him lifestyle modifications, he tries to remove his habits of smoking, alcohol, controls his sugars, blood pressures, etc. And he can retard the onset of critical events in his life like myocardial infarction or stroke. So it's beautifully said, penile attack equates heart attack. We are now seeing COVID as nothing but an endothelial disease. Diabetics have dual relationship. All diabetics had aggressive COVID, all COVIDs precipitated diabetes. So how do we manage erectile dysfunction, which is one of the male most common sexual disorders in male? He inside she, man inside woman, lad inside lady. What I want to convey here is the problem is in the man, but the solution will always lie in the couple. You all need to call the couple when a man comes to you for erectile dysfunction. There may be a menopause or andropause, but during sexual dysfunction, it's a couple pause. So couples should be counseled together. We have two beautiful questionnaires, IIEF 15 and SHIM 5. Beautiful questionnaires where you can diagnose severity of. Most important thing is try to rule out what is psychogenic erectile dysfunction. Ask a very simple question to your patients. भाई आपको 15 दिन में या 1 महीने पहले तक सुबह did you get up with an erection? If he says yes, friends, he does not have any organic erectile dysfunction. He has got psychogenic or situational erectile dysfunction. Very simple to do. We also do the following things, advise them on smoking, diet, exercise, blood pressure, lipids, sugars to be brought under HbA1c to be less than 7, eye, feet and oral hygiene to be examined every time when your diabetics come to you. We give them sildenafil 50 mg and make them sit, ask them to think erotic. If they get erections, it's purely psychogenic. We also give intracavernous vasoactive drugs like papaverine in the clinic, make them wait for half an hour. If they get erections, they've got purely psychogenic erection. Additional tests we do are serum testosterone free, total sex hormone binding globulin, thyroid, FSH, LH, prolactin, sonography of the scrotum, Doppler studies, digital rectal examination, and novel tests like Regiscan. I'm going to give you some beautiful tips where even without asking your patients, you can diagnose erectile dysfunction. Look at the CBC of their patients and do platelet and lymphocyte ratio. If the ratio is 104, he has got no erectile dysfunction. But if it is more than that, he's got moderate or mild. If it is 116, he's got moderate erectile dysfunction. If it is 136, he's got severe erectile dysfunction. Just by looking at a CBC, you can diagnose the severity of erectile dysfunction in your patients. And when you look at the report, when you mentally do the calculations and you found that the ratio is more than 104, then you can confront with him. He will call you Sai Baba, sir, how did you know? I have never told you this. You will do a great service to him. The other thing is neutrophil lymphocyte ratio beyond 3 is the most informative cutoff for identifying men with severe erectile dysfunction. Simple CBC. HSCRP is now a greatest predictor risk factor for erectile dysfunction. Endocan, a very simple blood test. You can diagnose endothelial disease and of course erectile dysfunctions. Testosterone, even have a orchidometer, look at the size of the testis. If it is less than 20 ml, he has hypogonadism. He definitely has low testosterone and erectile dysfunctions. Patients go to dermatologists and they give them medicines like finasteride, minoxidil for hair growth. Ask a history of it. Post finasteride, most of the young men develop the erectile dysfunction, which is at times reversible. And finasteride 1 milligram has been given by the dermatologist for 6 months, 1 year, 2 years, and things like that. Youngsters watch porn. They develop erectile dysfunction, which cannot be cured with PD5 inhibitors. Because of the aggression what they see in the movies, in the porn, that same thing they don't find in their bedrooms. So they don't get arousal soon. They are delayed arousal. And this is one of the common reasons for divorces today. Smoking damages everything in your, so please guide them. Sleep deprivation. So these are the very simple things if you take a history and can diagnose erectile dysfunction and start the treatment, counseling, give them all the advices what you can give, which I will tell you later. So how do we manage erectile dysfunctions? Oral therapy is the first line along with counseling and lifestyle measures. Second is injections of papaverine in the intracavernous tissue, vacuum therapy, intraurethral prostaglandins. If all these fail, we send our patients for implant surgery or anastomotic surgeries. But counseling and lifestyle is the backbone or the mainstay of treatment for any patient with sexual dysfunctions, leave aside erectile dysfunction. We have 4 PD5 inhibitors, sildenafil, vardenafil, tadalafil, sildenafil. All have varied onset of action and duration of action. Tadalafil has the longest onset of action, which is around 36 hours. All these PD5 inhibitors come with a bunch of side effects, flushing, headache, nasal congestion, dizziness, etc. The only contraindications we all should remember is these patients should not be on nitrates. Rest, everything can be managed. We have seen diabetics suffering. So we give them low dose of tadalafil 5 mg to 10 mg for a long period of 12 weeks. Irrespective of whatever be the HbA1c, whatever be the hypertension, even prostatic hypertrophy, dyslipidemia, they have shown improvement in their. My friend Dr. Jyoti Dev started putting insulin pumps in these patients and he found improved sexual functions in 85% of the patients. Metformin has now been shown to improve the endothelial functions. Not only it does give you, reduces the hyperglycemia, but it improves the endothelial. SGLT2 inhibitors, because of the class effects, weight loss, control of hyperglycemia, antioxidant effect, control of lipids. All the vasculogenic causes of erectile dysfunction are just covered up by SGLT2 itself, by the class property of itself. So if you combine SGLT2 with metformin and give it to your patients, you don't need to give them any additional drug like PD5 inhibitors, sildenafil or tadalafil. So you reduce the pill burden of it. Buried penis syndrome, very common. Start 1 gram of metformin, sesame seed oil, till oil, which has got androgenic properties, and L-arginine gel produces fantastic results in period of 6 months. There are a lot of novel therapies, low intensity extracorporeal shockwave therapy, platelet-rich plasma. But all these things are not curing or treating erectile dysfunctions. They're just improving the blood flow in the pelvic area. So what is the new tool which we have? Do we have anything? Yes, we've got regenerative medicine in the form of stem cells. Diabetics, 7 diabetics were treated with 15 million human umbilical cord blood stem cells infused in the corpora cavernosa. 6 out of 7 men regained morning erections in a period of 3 months. We have got L-arginine, which modulates the glucose and lipid metabolism in obese and diabetic patients. Fenugreek improves post-hypoglycemic activity. So the combination of these two, fenugreek, friends, have got a testosterone-like effect. The chemical composition is similar to testosterone. Takes care of the desire part of it. L-arginine produces nitric oxide, initiates the erections. So combination of these two without any side effects can give them a normal sex life. Enough studies to prove that erectile dysfunction and L-arginine administrations. And what's new in the treatment? We have avanafil, a beautiful drug, which has got the onset of action in just 15 minutes with no visual side effects, less myalgia, and the half-life is just 5 hours. So this is the only drug which you can give it to your patients who are also on nitrates. You can skip the nitrates on that day if he wants to have sex. He takes avanafil, has sex, this drug gets washed out from his body in 5 hours. Again, next day he can start his nitrates. So beautiful drug. Avanafil is the only drug which you can give it to your patients who are on nitrates. We have a surgical Tactra malleable penile implant processes. Beautiful, no side effects and all that. There are a lot of novel molecular targets for treating erectile dysfunction still in the pipeline. The second male disorder is premature ejaculations. So how to mature your premature ejaculation? See, premature ejaculation according to me is not a disease. There are no medical causes of premature ejaculation. It's essentially a psycho-behavioral and relational origin. All psycho-behavioral causes like anxiety, worry, fear, guilt, envy, being self-conscious, self-critical, these are all psychogenic issues. You can easily counsel them and make them better. And why I call it's not a disease? Because we have nothing to diagnose. There are no signs or findings on physical examinations. There are no radiological, pathological, hormone, immunological, hematological or any laboratory tests that can detect, grade, rule out or monitor prematurely. Purely exercises. Of course, there are a lot of drugs which are SSRIs which are available today. But all those also cause erectile dysfunction. So we treat them just by counseling and teaching them some exercises. Now we have seen erection disorders, we have seen ejaculatory disorders, but what we have forgotten is the desire, which is the foundation of a man's sex life. We've taken care of erections, we've taken care of ejaculation, etc. But what do we do with the desire? There is a therapeutic gap. Desire is the foundation. She has a desire and he does not have a desire. And desire is only because of free testosterone which is there. All diabetics are testosterone deficient. It is the free testosterone which is lacking, not the total testosterone. We all look at the report of testosterone, oh 300, 400 is within normal. But do a free testosterone and find out whether he's got less androgenic effects or not. So now we have thought very far. Let us think wide and think high. We know erectile dysfunction is due to endothelial dysfunction. So therapies should target the restoration of the endothelium, not just giving him blood supply. So we know that the risk factor of all risk factors is endothelial dysfunctions. And endothelial derived nitric oxide is an anti-atherosclerotic and anti-thrombotic molecule. So what do we do to improve the endothelium, to give him a cure on for erectile dysfunctions? Are there any pharmacological remedies? Yes, we have. Angiotensin converting enzyme inhibitors, statins, insulin sensitizers, L-arginine, tetrabiotin, so many things which are available can restore the endothelium and protect you against various diseases like peripheral vascular disease, stroke, heart disease, diabetes, insulin resistance, chronic kidney failure, tumors, venous thrombosis, and many. My teacher, late Dr. R.D. Lele, in 2007 published so many strategies to improve the endothelium which we have. So, what is new we need to know today? We need to know that the source, the science behind nitric oxide. What does nitric oxide do? It's a miracle molecule. It's a chemical currency of our body. It improves the blood flow. It increases the tissue delivery of oxygen and nutrients. It increases the body to get rid of the toxins. It reduces the blood pressure. It risks of sudden cardiac arrest and asthma. It improves the blood, expands the blood vessels by 26% of most of the vital organs like brain, kidney, penis. But sadly, this also reduces as we age like testosterone. So the bottom line is, if you do not have enough nitric oxide, you cannot have sex. So how do we get nitric oxide? We get it from L-arginine. Besides producing L-arginine, Dr. Ignis have won a Nobel Prize on discovering this, that L-arginine will produce nitric oxide, and it has got multiple benefits and no side effects at all. We all are aware of how it modulates. 17 years of our clinical practice with PD5 inhibitors, what have we learned? That these PD5 inhibitors are not the cutting edge pharmaceutical solutions for it. So we need to do something. Patients don't adhere to it. We have 40 to 50% of patients who stop taking PD5 inhibitor. They feel less self-esteem, etc. Remission of diabetes is not a new thing. It is a fact. It's not a myth. Coronary artery disease reversal has been proven by Dean Ornish long time back in his studies with intensive lifestyle. Genes, whatever happens to us is only genetically, which happens is only 20%. 80% of what happens is to us is because of our lifestyle. And most of the risk factors which we see are all modifiable risk factors which we have, which we can easily modify. Cleveland Clinic in their studies proved that nutritional intervention, only nutritional intervention, will not only halt but even reverse the coronary arteries. Look at this huge plaque, completely opened up just by nutrition. So the doctor of the future will no longer treat human frame with drugs, but rather cure and prevent disease with nutrition. So lesson to learn is, it's a shame for a man to grow old without seeing the beauty and strength of which body is capable of. Socrates said, we all can treat our patients, we all can treat ourselves. Which doctor cannot control diabetes, cannot cure hypertension, cannot control dyslipidemia? All of us can do that. All we need is passion. In the couples, I find couples hardly hugging each other. There is no romance. Friends, there is no GST on romance. Increase your romance. And the science of sexual fitness is love yourself. Avoid salt, oil and sugars, Mediterranean diet. Give a U-turn to your metabolic imbalance. Have a regular rhythm of sex life. Vitamin romance and vitamin touch is lacking. Husbands watch porn, wives are working in the kitchen. What is the signal the husband is giving to the wife? Wife knows what are you doing. You are giving her a signal that you like the girl more in the movie than her. Don't do that. Watch porn together and criticize the girl in the movie more. That's important. Bedroom is used for everything else except sex today. The bedroom ethics are, bedroom is only for sleep and sex. Today, there is no concept of afterplay. Men ejaculate, turn himself on the other side and sleep. Mera kaam ho gaya. This is wrong. What is afterplay is, once you have ejaculated, you need to hold your partner tight, hug her, thank her, compliment her, tell her she was beautiful, she was awesome, she did a wonderful job, and do everything what you did during foreplay again. This is must. Because if you look at a girl who's done a lot of makeover, etc., anybody would tell, oh, she's gorgeous. But if you compliment your partner in that bedroom after having sex, you are giving her a signal that you like her the way she is, and that speaks miles. Friends, don't use your partner as a sleeping pill. Mutual satisfaction is important. We call it samabhog. What women can do, Regard him as a hero. Yeda hai, teda hai, lekin mera hai. Don't worry about it. Never give him any pressures to perform. Get a makeover done. All these women were abandoned by their husband. They got the makeover done again. So spend your husband's money as much as you can. Do whatever makeup. Try and look as beautiful as possible. My last few slides. So take home messages. The onus of sexual health of your patients lies with you. You have to break the ice. You have to come out of your clinical inertia and ask your patients one simple question. Do you have problems in making love? Not a vulgar thing. You'll be surprised that your patients were waiting for you to initiate a dialogue on this. Teach them what is realistic thing. Give them realistic expectations. Don't give them wrong. What a physician misses is giving time, not taking a detailed history, counseling, educating on realistic and giving an emphatic ear. Lifestyle. You may be Hindu, Muslim. Make your lifestyle as your first religion, because lifestyle will improve everything in your body. Two-time Nobel Prize winner Dr. Linus Pauling declared that nearly all diseases can be traced to a nutritional deficiency. What else you want? A brilliant man who won 2 Nobel Prizes giving you a hint that you can cure everything with nutrition. So we have all PD5 inhibitors. They don't increase the desire. 40% are non-responders. So the Basha is testosterone, but we need to give it with caution. We can't give it to young patients because of azoospermia, heart failure, and prostatitis. So who's the Raja of all? We have L-arginine, fenugreek, lifestyle modification, and region. Friends, we need to learn to respect feminism. Feminism needs to be adored, admired, trusted, and respected. Look at Mahabharata, look at Ramayana. If any man doesn't respect feminism, I pray to God that he should get permanent, incurable erectile dysfunction. Love each other unconditionally, because we are all born out. Love is a flow, it is creative. That is why it flows and brings contentment. This contentment is much more deeper and valuable than contentment after sex. One who knows that contentment will never look for any substitute, just like a person who acquires jewels never seek for pebbles or stones. Children should be taught to love from infancy. The myth that teaching of love will lead to child into the world of sex is frivolous. This fear is groundless. The more love grows in a person, the more sex energy is transformed into sex and is shared. The less love filled a person, the more sex minded, more hatred a person has, the more jealousy, competitiveness, worry, unhappiness, etc. Be fearless and passionate even in the bedroom. Try and cultivate your... Be monogamous. Being monogamous is like a garden. Being polygamous is like a jungle. You have to decide whether you want to be a gardener or a jungle. So Voltaire beautifully said, try and cultivate your garden. Sexual dysfunction is not an option. It can happen to anybody. It's how gracefully we handle the process and how lucky we are as the process handles. So for sexual dysfunctions, we've got so many things to give to our patient that these functions can be easily managed. It's really nice to know that erectile dysfunction today is a correctile dysfunction. If you have patients for erectile dysfunction, treat yourself. Don't send them to quacks. Please treat yourself. You can do it. If you can't treat, send them to a good sexologist. He will see that he gets a good erections. This is my book, Sex Has No Expiry Date. My last slide. Male sexual disorders are no more an enigma. Premature ejaculation, low desire, and erectile dysfunction are very common. Erectile dysfunction is surely a tip of an iceberg. Is endothelial dysfunction and emotional dysfunctions. Early diagnosis can prevent early death. Low-dose PD5 inhibitors, statins, regenerative therapies, lifestyle modifications are a promise to cure erectile dysfunctions. If done, erectile dysfunction is a correctile dysfunction. And if so, friends, sex really has no expiry date. Thank you all for your love. I'm sorry to take 5 more minutes. I'll be happy to answer any questions.
Yes, sir, this is a oration. We are having a no question answer session in this, and we have to complete this session. Thank you, sir.
So I request the audience to avoid your dysfunction while standing, to avoid your bad posture, to release your stress. Please stand up and clap loudly. Thank you, sir, for your lovely, manly talk with GST, which is an unmet need of the society. Now, I request our President, Dr. Mitesh Shah, to join our chairpersons to felicitate our orator of today, Dr. B.J. Vasa oration. Dr. Jumani sir with a shawl and a memento. I welcome all the chairpersons to come down the stage for felicitation, for which I request Dr. Ketan Shah, Dr. Tushar Shah and Dr. Bakulesh Chauhan to felicitate our chairpersons, Dr. Mitesh Shah, Dr. Samir Shah and Dr. Neeraj Chavda. To chair the next session, I welcome Dr. Bhadresh Modi sir and Dr. Anuj Garg sir, along with Dr. Nutan Ben Shah on the stage. Dr. Bhadresh Modi and Dr. Anuj Garg, both of them are respectable and leading physicians of Baroda, and Dr. Nutan Shah, a practicing ophthalmologist. Now, I welcome Dr. Darshan Bankar sir on the stage for his talk on advances in non-coronary intervention, and I request the chairperson to introduce Dr. Bankar sir.
Hello. Good afternoon, sir, everybody. So now we have one of the most dynamic cardiologists of Baroda. We are proud to have Dr. Darshan Bankar as a sir, our member of IMA Vadodara. Basically, I feel he really doesn't need introduction. He's not only a national faculty, he's an international faculty. And there is so much work that he is doing, not only on the level of cardiology, but in general, even for the fitness in Baroda and helping out people for the CPR and training in Baroda. He has actually, to some extent, I can say, made CPR a very common term and understandable term for all the Barodaites. So he has surgeries of 25,000 and more angiographies to his credit, more than 10,000 angioplasty, and a Gaikwad Gold Medal for the academic excellence and nomination for Vikas Ratna. And actually, I think we keep seeing his and Dr. Parulben's photos in Times of India, which is by itself a great matter of pride for all of us. So welcome, Dr. Darshan.
Well, thank you, madam. And first of all, I would like to congratulate Mitesh and the whole team for organizing such a wonderful conference. Neeraj, Mehul, Samir, and I'm sorry if I've forgotten somebody. Pragnesh, everybody has worked so hard. And it has been first time in Baroda we have seen IMA so active and so well organized, doing such a wonderful conference. So 3 cheers to them, and we all should back them for the future events and future things they are going to do. The 2 lectures are connected, I think. The first was on sex, now it is on heart. And both are interconnected. Because many of my patients, I don't know, Dr. Jumani, if patients ask you he has a heart problem or not, and what to do when there is a heart problem. But most of my patients ask me, or if they don't ask me, I tell them that when can they have sex after heart problem. So that's very important for us also as a cardiologist to understand. Okay, ऐसा है, ठीक है. He's taking time to reconnect, so I done? Yeah, okay. Yeah, got it? So now cardiologist has to become an all-rounder. The time has come that the whole scenario has changed, and we do a lot of coronary interventions. But beyond that, coming to vascular thing, let me tell you that to do any form of vascular procedure, cardiologists are the best people. Technically, they are more sound than most of the so-called neurointerventionalists or peripheral vascular specialists, because they love and play with coronaries, which is the smallest and moving vessels. So when it comes to other vessels, they are always experts in that thing. Not that I'm going to talk only about that when I talk of beyond coronaries, but there are a lot of things which I'm going to tell. See, this is an all-round cardiology, not only coronaries. We are not only plumbers, we are beyond plumbers also. So first thing I would like to tell you something which we have done for the first time in this city was valve-in-valve. What is valve-in-valve? It's basically a procedure which is done for an artificial valve, who a patient already had an artificial valve in his heart, and we have done a re-procedure when this valve get blocked or stenosed, what we call. We do a re-procedure, and that is done percutaneously in this patient, and we put in through transcatheter therapy, we put another valve, what we call valve-in-valve therapy, or a trans-aortic valve replacement in this patient who was a 69, had a paramount pericardial bioprosthesis in aortic position. Okay. It is closing down, so I don't know what is the... Well, this procedure is quite unique in that usually we put even the in TAVI valve is put in native valve. This is put inside a artificial valve. So that's how we did it. And it's done through, it's quite a complex procedure. Not that we are an expert on that. We have a team of people who come and proctor us and guide us to do these things. And obviously in another 2-3 years, we will have our own people who will be doing this procedure because it's becoming more and more frequent. The way it is going, I think in another 5 to 7 years, that valve therapy, the TAVI will become the first choice of therapy in all these patients. So, you will have to restart. Anyway, so this therapy has become more and more widely accepted therapy, and there are a lot of trials going on for putting valve electively and not preferring surgery is becoming a norm in many of the countries for moderate and severe aortic stenosis. So maybe in another 3 to 5 years, all patients who has a moderate to severe aortic valve stenosis will undergo a percutaneous procedure rather than a surgery. The way we undergo angioplasty in this group of... Yeah, chalega. That's okay. So that is also going to become the norm in another 3 to 5 years. What we do, I'll just show you the procedure because in today's world it is very tough and difficult to talk without slides, and you will not even understand what I'm going to talk about. This procedure has become, we know the procedures which we can do for aortic valve surgery includes TAVR, which can be done through femoral, transapical or transaortic. Usually what we prefer today is a femoral because the access now has become much easier and we are doing it. Otherwise what we do is a surgery or a minimally invasive surgery. So these are the options. I can? Okay. So there are various valves which has come in vogue, and in today there is a more improved delivery system and more improved valve made from porcine pericardium and a nitinol stent. Next slide, please. And the valve which is we are using nowadays is from Medtronics, what we call a Evolute R valve, which has a control over it. So anytime you can retrieve that valve from the body also. So if you have not placed that valve properly, you can just retrieve it and deliver it again. So that's the beauty of this valve. And obviously the procedure was done through femoral, and we go into this is a old valve, Perimount Magna. Next. And we introduced a 14 French caliber, which is 14 French is quite a large bore catheter through the valve, and then we dilate it, and sometimes we have to dilate it or we put the valve directly inside that. So the valve is delivered in that area. Next slide, please. And after delivering the valve, the gradient, which was like 80 by 60, became maybe 10-12 peak gradient. Next slide, please. So, and there was absolutely no aortic valve rigors seen, and patient went home in day 3. So that is how it is. Next slide, please. Well, I'm not going into detail of the procedure. The other thing which has come up and has become a passion for me is neurointerventions. We have been in stroke interventions for last 1.5 years. We have already done more than 18 neurointerventions by now, and we have been progressively doing more and more numbers of interventions. I will try to show you 1 or 2 cases which are quite interesting. Next slide, please. This was a 58-year-old male patient who came to us with an acute inferior wall MI, was thrombolized with reticulase already, and he underwent an angioplasty. Next slide. And obviously patient was underwent an angioplasty. After that he was shifted to wards, and in the wards he developed a stroke. I don't know whether it was a intracavitary thrombus which migrated or he got a thrombotic stroke. So his power was grade 0. Since he was already in the hospital, we realized that this is acute stroke. We can do a neurointervention straight away. So the patient underwent from 0 power. We took him into cath lab. Obviously we did a CT. This is very important that none of the patient in a stroke should undergo MRI straight away. When you are thinking of putting either patient giving a thrombolytic therapy or a neurointervention, the thing which you have to do is a CT scan and CT angio. Because MRI, number 1, takes away a lot of time, and MRI is not useful for the people who are doing neurointerventions. You have to do a CT angiogram with a plain CT followed by a CT angiogram, and that's it, and send patient directly to cath lab. Earlier you do neurointervention better. In cardiac, you may take some time, it's okay. But in neurointervention, you cannot afford to take any amount of time. So obviously this patient was showed thrombotic occlusion of left ICA and MCA, what we call a LVO or a large vessel occlusion was there. Next slide, please. So if you see, the left internal carotid artery was thrombotic occlusion was seen from here only, and obviously the above also it was occluded. Next slide, please. And if you see pre-procedure, it was totally occluded from the beginning of the whole intracranial circulation. And this was post-procedure. We did a thrombosuction and put a catheter inside what we call a penumbra devices. So through penumbra catheters and devices, we did a complete thrombosuction and thrombectomy. Next slide, please. And obviously, previous slide. So patient recovered totally, and his power was grade 5. Okay, next slide, please. So this was another patient who had obviously came with a right-sided hemiplegia. Next slide, please. And obviously his power was, minimal power was there, otherwise nothing else. Next slide. The obviously CT angio showing, actually he underwent an MRI and it showed a left MCA with left frontoparietal infarct. Next slide, please. And obviously his left MCA was totally occluded and it was opened up by doing a thrombosection and therapy. Next slide. He improved remarkably within 24 hours and next slide. You can see in 24 hours he was able to sit, which he was not able to, not getting up. And day 3 he was able to walk. He went home walking. Now just imagine, out of 19 patients we have done, we have lost 2 patients. We have given such a quality life to almost 60%, almost 12 patients. And this is happening all over the world. And this is the therapy which has come up, and all of us should get ready to offer our patient this therapy. This is very critical. Your 1 hour delay will make the family suffer for next 10 years. Okay, this is very important to understand, that your 1 hour delay of sending and convincing patient will make not only the patient but the family suffer, because neurology paraplegia or hemiplegia is not only to the patient, it is to the patient family also and patient's relative also. So a 1 hour delay or a 2 hour delay in offering a procedure or doing a procedure will hamper his life for maybe another 10-15 years. Next. So I'm not going into detail of this, but this has become a very effective and important therapy for all patients with an acute stroke, not having hemorrhagic stroke. And this should become, it's not necessarily a first line of therapy, but thrombolytic is also a very good therapy, but it should become a first line of therapy in another 3 to 5 years when we have a better systems and better protocols available to us. Next slide, please. So this is the thing which is going on, and mechanical thrombectomy, what we call MT, has emerged most effective treatments in stroke therapeutics. A strong absolute benefit in favor of for a thrombectomy over intravenous thrombolysis and standard medical therapy has been noted in first 6 hours, not only in first 6 hours, but beyond that also, up to 24 hours it is seen. But mind you, again I am telling the same thing, that an hour you save for the patient, you save him for 10 years of life. Next slide, please. Well, this is also one of the very passionate procedures which we have started doing, and we have developed a huge protocols and standard operating procedures for pulmonary embolism. And this is indication for pulmonary embolism therapies that is pulmonary embolectomy, are more and more important to us. And by now, in last 1 year, we have done more than 25 pulmonary thrombectomy with a device system, either angiojet or penumbra, which is a very wide bore catheter which we put in pulmonary arteries and attached to a specialized suction system called angiojet, and we remove the whole thrombus from that by Venturi effects, and create a sort of what we call a thrombolysis in a way. Next slide, please. So obviously goals of catheter-based therapy include rapidly reducing pulmonary antipressure, RV strain, and decreasing the load on the artery. Next slide. And mechanical thrombectomy is a benchmark therapy, especially in patient we get, I'll just show you one of the cases, especially fracture femur or fracture patients who has a pulmonary thromboembolism. It is one of the most, because you can't give thrombolysis to such patient. This is the therapy which we should offer to such patients. Next slide, please. And aspiration through angiojet or penumbra has become a standard therapy now, and we have been using it. Actually, we are one of the first in Asia to use GUJARAT using a special guided catheter in whole of Asia. This was the first time we did it. In the last 3 months, we have used it in almost 6 patients of pulmonary embolism. Next slide, please. So, another form of therapy which we can do is a catheter guided lysis, because you can reach up to distal pulmonary arteries and you can give a better effective thrombolytic therapies to such patients. Next slide, please. So this is just a 35-year-old patient, and thrombolyzed outside with tenecteplase, and obviously there was still a RVSP of 120, and there was a huge thrombus inside the pulmonary arteries, and CT angio was repeated, and obviously his right lower limb also had a DVT involving deep femoral vein. Next slide, please. So this is the large ball catheter. You cannot see anything inside the left lung, and this was post suction. You can see the whole peripheral vasculature coming up and filling up. Next slide, please. So this was the picture. Actually, it was totally thrombotic occlusion. It opened up. You never get 100% lesion like coronaries in pulmonary arteries. But the moment you start getting peripheral vascularity, it is a good success in such a case. And obviously, he also had a distal DVT. So we put an IVC filter for us, which is a retrievable thing, which we remove usually after 3 to 6 months. Next. This was another patient who had a similar thing, and his RVSP was 75. We did a venous Doppler, and we removed the thrombus. Next slide, please. So obviously, these are the catheters which are put inside the pulmonary artery to remove the thrombus inside the vessel. Next slide. Yeah, go ahead. So this was angiojet machine which we use to remove the clots from the pulmonary artery, from the peripheral veins, everything. Go ahead. I think I'll drop this case. This was a venous thing which we removed from the veins. The another thing which I just wanted to tell you is about the leadless pacemakers. So this is something which is coming up, and we were the first one in Gujarat to put first leadless pacemaker. This was almost 3 years back. Now we have put almost 4 leadless pacemakers. Next slide, please. Go ahead. So obviously this was one of the unique patient who had a SVC obstruction, and there we had 2 options. Either we put a femoral long wire in pacemaker and put a pacemaker in abdomen, or we put a leadless pacemaker. So we chose to put a leadless pacemaker. Next slide, please. Next slide. So this was an obstructed SVC, and no way we could put a pacemaker through the SVC. Next slide. Next slide. So this is a pacemaker which is put inside the cavity of the right ventricular cavity. Next slide, please. So this is how it is placed inside the right ventricular cavity. Next slide. And this is actual procedure of putting a pacemaker inside that. Next slide. So this is how it remains inside the heart. So usually we put a pacemaker over here in the subclavian area. This is intracavitary pacemaker, which is a leadless. You don't need any leads to put the pacemaker. Next. This is one of my dream things which we have started around 7, 8, 10 years back of renal sympathetic denervation. This is a therapy for resistant hypertension, but I feel in another 5 to 7 years it will become a therapy for many of the patients with moderate to severe hypertension. And we have by now done 60 cases of renal sympathetic denervation, which is one of the largest number in, I would say, in India. I was one of the first to be trained officially for this renal sympathetic denervation therapy. Next slide, please. Where we do, it's basically what happens in hypertension is there is sympathetic overactivity, there is renal activation which happens. So the principle is you denerve the sympathetics of the renal arteries, because all sympathetic system passes through the renal arteries. So we do a ablation of these nerves, and by that you are making it, the sympathetic overactivation is removed, and that reduces the pressure. I would just give you one example. I had one patient from Valsad area. Her weight was 120 kg. She had a sleep apnea, severe diabetes. Her pressure was 220 by 140. She was on 4 drugs, antihypertensive, 5 drugs. And in spite of that, pressure was not controlled. We did this. Within 6 months, her pressures came down to 140 by 90. And her weight reduced from 120 to 90 kg. Diabetes got controlled. After 3 years, she is still in my follow-up. Her pressure still remains 140/90. Now, all of you have seen patients with 220, 140 pressure, very difficult to control. This is the therapy. And actually, it will be very soon, there would be a formal announcement of this therapy world over after the trials which has undergone. Next slide, please. Next. So, next slide, please. So this is the mechanism which I told. It is a renal denervation, prevents failure, reduction of renal blood flow. And next slide, please. And obviously, it's a very simple, straightforward procedure. It takes hardly 1 hour to do this procedure. It's basically a transfemoral procedure. Next slide, please. And we put a catheter inside the renal artery and ablate the nerves inside the renal arteries. Next slide, please. Next slide. So this is a kind of catheter available. Now a newer generation of catheter is available which is more effective and would be very effective for especially resistance hypertension and severe hypertension patients. Next slide. Next slide. So this is how we do it. We put a catheter inside. Next slide. And we check that there is no renal artery stenosis. Next slide. And then we do put a ablation catheter and do ablations of these sites. Next slide, please. Next slide. And we usually give 8 to 10 cycles of ablation inside the renal arteries to kill the, I would say, ablate the sympathetic nerves inside the renal arteries. Next slide. Next slide. I don't want to go in details of the various trials which are available now for this thing. Next slide. This is obviously one of the fellowship program, what was a transcatheter renal denervation, which I attended first time in 2011. So since then, we have been doing this procedure regularly. Next slide, please. So again, coming back to that, you have to be all-rounder to do a lot of procedures in cardiology now. Cardiology is not only coronary intervention, it has gone much, much beyond that. So I thank you all for patient hearing, and I would be very happy to have questions.
Any questions? Meanwhile, in one line, Dr. Darshan Bankar, the Jadugar of Baroda, showing us very high-tech, advanced scientific jadus. They were miraculous. Any questions, please?
We are running short of time. I request all audience to stand up and clap loudly for the Darshan Bankar, sir.
Thank you, thank you. Thank you.
A big round of applause.
Thank you.
Now I welcome you down the stage for felicitation. I request Dr. Mitesh Shah, sir, to present memento to sir. And I also welcome all chairperson to come down the stage for felicitation, for which I request Dr. Ketan Mehta, sir. Yes, sir. Now I welcome Dr. Drumil Patel, sir, on the stage for his talk on preservation of natural knee, that is MIS approach, minimum invasive surgery approach, and I request the chairperson to introduce the sir.
So welcome Dr. Drumil. He is an orthopedic surgeon and now he has so many more adjectives. He is specializing in sports medicine and joint replacement. He has not left any joint untouched. He has been a fellow for shoulder, hip, knee, foot, ankle, wrist and hand. And as a sports medicine orthopedic surgeon, I'm sure he'll be doing very well. So over to Dr. Drumil.
Thank you, madam, for the brief intro. All right, so we have a lot of senior surgeons talking about erectile dysfunction and chest pain, which is very common in our body. I'm going to talk about a relatively common knee problem that we have in orthopedic practice. And because it is very common, a lot of orthopedic surgeons today try to adopt various minimally invasive techniques for knee preservation so that the patients have a better post-operative result. And I'm going to discuss a few of the techniques that we do in our routine practice today. As madam told, I am an arthroscopy sports medicine surgeon at Navrang Hospital, Vadodara. Knee today we use in daily activities like going up and down the stairs, jogging, running, because a lot of cardiologists, a lot of gastric surgeons, a lot of physicians advise their patients to do some physical activity for their fitness. So knee is routinely used in our daily activities. A lot of us are fond of doing yoga, gym training. That is where we damage most of our knee menisci. So knee pain is very, very common today. A recent Times of India article in 2019 suggested that there are almost 15 crore people in India who have knee arthritis. Out of them, 4 crore require total knee arthroplasty. So what to do for the other 11 crore people who are there with knee pain? So minimally invasive technique is something that we can do for them. How to treat young patients with knee pain? Sports medicine or arthroscopy allows us to put a scope inside the knee joint with a percutaneous small incision. And with small arthroscopic instruments, we can repair various structures inside the knee joint. All of us are aware of the anatomy of the knee, femur, tibia, fibula, and various ligaments which form the knee joint, as well as the menisci, which are the main shock absorbers of the knee joint. I'm going to briefly tell you the arthroscopy setup that we have for knee and what we see when we go inside. When you put a scope inside the knee, the first thing that you see is the patellofemoral joint. On the top, what you see is patella, and below is the femur. The next thing that you see is the cushion of the knee, the cartilage. And then the shock absorbers in the knee, that is the medial meniscus and the lateral meniscus. The final structure that is important inside the knee is the ligament, the anterior cruciate and the posterior cruciate. And that's a video of an arthroscopic probe probing onto a normal anterior cruciate ligament of a young patient, probing the lateral meniscus, probing the tibial insertion of the ACL, and then probing the medial compartment of the knee, the cartilage and the meniscus. So with the help of a small percutaneous incision, you can go inside the knee and address various problems that young patients have today. What are the common knee problems that we come across? A lot of us have anterior knee pain, which is chondromalacia patelli. Going up and down the stairs is a problem for the patients. Sitting up from cross-legged position is again a problem. Why do they have this pain? That is mainly because of softening of the cartilage on the patella, mainly because of vitamin D deficiency. When we go in with a percutaneous incision, the fibrillated cartilage that you see on the patella, that is chondromalacia. When you flex and extend your knee, that fibrillated cartilage comes in contact with the femur, and that is what causes you pain. So with the help of a small 3 millimeter shaver, you can remove this chondral injury from the knee. You can clean the patella and make the patient pain-free with just 2 small incisions. The other thing that we can do is denervate the patella with the help of an electrocautery arthroscopic probe. Just denervate the nerve endings. If the defect on the patella is big, then we do an open surgery for the young patients, and we graft the defect in the patella with a natural cartilage from the femur. We take autograft from the trochlea of the femur and implant it on the patella like this. That is what we do for cartilage injuries of young patients. We do a good closure so that they get good range of motion. If the defect is bifocal, both on femur and patella, then we do something what is called as autologous cartilage implantation, the stem cell implantation. So that is a small video which shows you how we implant stem cells onto the cartilage defect in a young patient with a knee problem. That is the final implantation which sticks there with a fibrin glue. Sometimes some patients have excessive grinding, excessive crepitations in the patella, then we opt for elevation osteotomy of the patella, which is what it looks like this on a post-op X-ray. We advise most of our patients with knee pain to wear braces for 6 months. We put them on calcium with multivitamins that are very important for their healing. We put them on a strict diet plan. I think all of us know what is good diet by now. And weight loss helps them to keep their knees pain-free. Arthroscopic treatment of cartilage defects in the patella has been found to have a very good result in most of our patients in young age. What about meniscus tears? A lot of us today are involved in sports. So when you have a twist injury while playing sports, you have a meniscus tear inside your knee joint. A lot of old age patients come to our clinic with degenerative menisci because of overuse of the knee. How does it look like when you put an arthroscope inside? That's the medial meniscus in the medial compartment, and that's the lateral meniscus. That is a normal lateral meniscus in a young patient. It is the main shock absorber of the knee, so it is very, very important to preserve the knee. That's a young patient with a knee injury with a completely torn meniscus, medial meniscus. Very, very important to put it back near the peripheral capsule. And then we use advanced arthroscopic repair techniques and put various stitches inside the meniscus and fix the meniscus to the peripheral capsule so that it heals properly back to the capsule. So that's a short arthroscopic video which will help you understand how we repair an acutely torn meniscus. That's a stitch that goes right up to the posterior aspect of the knee, just beside the PCL. Once we repair the posterior portion, then we come to the middle and the anterior portion. And we put multiple stitches and fix the meniscus to the peripheral capsule like this. And these small percutaneous incisions help us go inside the knee and visualize the various problems that we have in the knee and address it in a very, very minimally invasive way. These are the small portals that we use for our arthroscopy, and that helps us to repair the meniscus. That's another case with a complexly torn meniscus. And once you put it back and stitch it back, believe me, it heals in young patients. That's the image at 3 months post-surgery, nicely incorporating the meniscus. For old patients with a degenerative meniscus tear, when there is no scope of repair, or if we know the repair is not going to help, then what we do is debridement or refreshening of the meniscus. We remove loose bodies from the meniscus with the help of an arthroscopic shaver so that these patients don't have problems of mechanical locking or clicking inside their knee. And then we use electrocautery probe to coagulate the collagen tissue that is there inside the meniscus and make it stable so that it is not prone to re-injury or to get torn again with a twist injury. That is the final stability that the patients get. Meniscus repair in a lot of studies has been found to have 70 to 90% healing rate. So very, very important to preserve the meniscus in today's practice. What about ligament injuries? A lot of us as orthopedic surgeons are fond of repairing the ligaments in young patients, and it can be done in a minimally invasive technique. So what are the problems that the patients have? They have laxity in their knee. That is the main problem. They are not able to balance their knee while they walk or go up and down the stairs. And that's a short video which will illustrate how the tibia subluxates anteriorly when the patient has a ligament injury. When you flex them and try to assess the stability, they are again unstable. Medially and laterally also they are lax when there is a cruciate ligament injury. So they're not able to walk properly or run on their normal knee. So when we go inside, this is a normal looking anterior cruciate ligament. For repair of the ligament, we go in with an arthroscope, and that's an acutely torn ligament with hemarthrosis inside the knee joint. We clean up the ligament, create tunnels in the tibia and the femur, and then try to put a new ACL ligament into the femoral socket. Where do we harvest the graft from? We harvest it from their own body, either the hamstrings or the peroneal near the ankle, or we take central quad tendon near the knee joint. And then on the back table, we prepare this graft into a thick 10 or 11 millimeter 4-fold graft and fix it with small incisions inside the knee with various suspensory fixation devices. That's a button which goes on the femur. It flips on the other side of the femur, and then we can pull the graft into the femoral socket like this. And finally, when we test for the stability, we know that it is stable because it has been fixed on both sides of the joint. What about an acutely torn ACL from the tibial side or from the femoral side? Whether there is an acute fracture, there is an acute avulsion, then we try to remove all the blood from the knee joint. And then we pass various sutures through the ACL and fix it back to the bone. And that is how we actually repair the original ACL in a young patient. So eventually at 3 or 6 months, they will be walking and running with their natural ligament. So there are also ways of reconstructing and repairing both the ACL. These patients are found to have excellent results even 20 years post-surgery. So very, very important to use minimally invasive ways of treating the ligament injuries. What about the collateral ligament injury, the medial and the lateral collateral? They are on the side of the knee. And the main problem that they have is when they try to stand, they're not able to stand straight because of the instability that they have in extension. So you can see the medial joint is opening up, even the lateral side of the joint is opening up because of the ligament injury. So they require a formal open repair because these ligaments are outside the knee joint. You cannot go there with a scope. So we do a formal side-to-side repair of the ligament for collateral ligaments. Very, very important to do early surgery, early good rehab for better outcomes in most of our patients. What about middle-aged arthritis? We see ligament injuries in a lot of young patients, but a lot of 40 years, 45 years, 50 years, males and females, they come to us with knee pain. And it is very, very important that we don't offer joint replacement to these middle-aged patients because joint replacement as such is a treatment for patients 60 and 65 years and above. And so when young patients, 35, 40, 45 years of age, they come to us, they have knee pain and we need to find some good solution for them. What we do is an osteotomy and I will show you how we do it. Most of our patients are present with medial joint line pain. Why do they have it? Well, most females have it because of postmenopausal osteoporosis. That is what has been found in our routine practice, and also because of obesity, weight gain, because the knee has shock absorbers which are gone and the weight is on the knee, and that is the reason why they have arthritis. So most of us have bent knees like this and the load is on the medial side. And that is the main reason why they have young age arthritis in the middle age. You can see this X-ray, long axis X-ray, and you can see the load is on the medial side. And when you have a 43-year female like this, with a completely torn menisci, arthritis in the knee joint, there are holes inside the medial compartment. But this patient has good lateral compartment, as you can see over here. So what we do is, we shift the load from the medial side to the lateral side by doing an osteotomy in the tibia and fixing it with a plate. And now what the patient has is a straight leg and the load is in the center of the knee, and this gives them a natural knee for at least 15 to 20 years of their lifetime. So the left side of the image is pre-surgery, right side is post-surgery. Making the knees straight gives you a natural knee for at least 15 years for a middle-aged patient. If you have knock knees, well, the osteotomy again can be done, but here we do it on the femoral side because the deformity is actually in the femur. And we can fix it with a plate and again make the knee straight like this. Sometimes, in some patients, we have to do a double-level osteotomy to make the knee straight for middle-aged patients. So middle-aged arthritis is a concern for most of us, and we can treat them with osteotomies. What about rehab? Do they require good rehab? Yes, basic to advanced, and we focus on good rehab for all our patients. Most of them with arthroscopic surgeries, they're able to resume their normal walking patterns 3 to 4 weeks post-surgery. This is a patient with a multiple ligament knee injury who is back to his routine deep squats 3 months post-surgery. We do intensive strengthening training for most of our patients and also work on their proprioception post-surgery because it is very, very important that they resume their normal activities or sporting activities at least 9 months post-surgery. So that is rehab at 3 months post-surgery. We work on their agility and make sure that they are able to go back to their field feeling safe about their natural knee. So minimally invasive surgery really gives them good results, less pain, faster recovery, easier return to sports, and for all the middle-aged patients who have knee pain, it gives them easier way of resuming their normal day-to-day activities. MIS in knee replacement is the latest thing that we do. We use the same techniques, small incisions, muscle preserving techniques. We retain the cruciate ligaments in most of our patients today and try to give them a more natural feeling of their artificial knee. Robotics has helped us in a big way in giving an MIS surgery for arthroplasty patients. This is the Johnson & Johnson Valley's robotic system. We in Gujarat are the first one to get it after Diwali and only second in India. We are going to start it this January for our patients, robotic knee replacement. Preservation of natural knee is not just a role of a surgeon. I think patient has a very important role in trying to get a good knee. What we advise most of our patients is to exercise or involve yourself in some light sport. Exercise is not only for the young, it is also for the aged. Very, very important to remember that you need to have proper shoes, proper knee braces, proper equipments while you are exercising. You don't want to over-exercise and damage your ligaments inside the knee joint. For most of the middle-aged and elderly aged people, what we advise is ensure that you walk on soft surface, on grass or on matted surface and not on concrete. Because when you walk on concrete, you are loading your knees more than what you are doing when you are walking on a soft surface. For the young people, using good sports shoes is the standard thing that we advise them, and that helps them to preserve their knees for a longer time. What about diet? I think weight control is one of the very, very important aspects of the minimally invasive surgeries that we do. And we ask our patients to incorporate good vitamin D and calcium in their diet, mostly milk, curd, oranges, and green leafy vegetables. So remember that MIS surgery for knee, for a natural feeling of your knee, is not just a job of your surgeon, it is also the job of the patient. Hope this lecture helps you to keep your knees healthy. Thank you.
Any questions? So I request everyone to preserve your knees, to maintain good health of your patella and menisci. Stand up and clap loudly. Thank you, Dr. Drumil, for your excellent talk. I am sure कि आपके सब patients आपको दुआओं में याद रखते ही होंगे. Now I welcome you down the stage for the felicitation. I request Dr. Rahul Parmar to present the memento to Dr. Drumil. I request all the chairpersons to come down the stage for felicitation, for which I request Dr. Ketan Mehta, Dr. Karshit Joshi and Dr. Rajesh Salvi to facilitate our chairpersons, Dr. Bhadresh Modi, Dr. Anuj Garg, Dr. Nutan Shah.
Good evening all. Now we are moving very important session of this day. Late Padma Shri Dr. V.C. Patel scientific lecture and Dr. P.R. Trivedi oration. So
for today's MOC, which was done so very well and flawlessly by Dr. Bhupendra Kapadia and Afsana. 3 cheers to them, and we all should clap for them. And the idea of getting up every time for each speaker was such an excellent idea by Dr. Neeraj And in spite of a little thin audience, it is so gratifying that we stood up and applauded all the speakers. Thank you so much.
Thank you all. So now we are starting with our very important session. I invite our chairperson, Dr. Vinod C. Shah sir, senior family physician practicing since 44 years, past national senior vice president, Indian Medical Association headquarters, past president IMA Gujarat, past director HBI IMA headquarters, and past national president FFPI. We have also one more dignitary with us today, Dr. Bhupendra M. Shah sir. Welcome sir. He is national vice president IMA headquarters past, honorary state scientific secretary Indian Medical Association Gujarat state branch, national committee de-addiction headquarters Indian Medical Association Delhi, vice chairman Junior Red Cross Gujarat. So welcome sir. Now I invite Dr. Vinod C. Shah sir for late Padma Shri Dr. V.C. Patel scientific lecture. The orator is Dr. Anil Jha sir. I invite Vinod Shah sir for his introduction.
Thank you sir. Good evening to all valued dignitaries, guests and registered delegates. I feel honored to introduce Dr. Anil Jha. Anil Jha did his MBBS MS from the Gujarat University and pursued his CMC Vellore. He went to UK and studied in Kingston Hospital during the period of 1995 to 97. He is a non-doctor and a skilled cardiac surgeon, but is a rare combination of sensitivity and courage, a philosopher, a writer, a sadhak, a musician, a scientist, an environmentalist, a research scholar. Thus, he is a multifaceted, multi-talented, and multi-dimensional personality. His wife, Dr. Jyoti Ben, is also a well-known interventional cardiologist practicing at Nadiyad. This couple came back to India on clarion call of Yagnapurus in 1997. Then Dr. Jha started his practicing in cardiac in Nadiyad as well as in Ahmedabad since 1997 and performed more than 6,000 cardiac coronary bypass surgeries, valvular replacement, and congenital heart defects. He has also prepared the documentary Pannataman Tatsavitur Varenyam in Gujarati, which was dubbed in Hindi too. He has conducted extraordinary research on applied science of Yagnapurus. Sir, with these few words, I present our today's speaker, Dr. Jha, to you. Welcome, Dr. Jha. Time allotted to you, sir, is 20 minutes. And topic is clinical and spiritual impact of sound. Sir, please give him a big round of applause.
Welcome Dr. Anil Jha sir for prestigious late Padma Shri Dr. V.C. Patel scientific lecture.
धन्यवादाः डॉक्टर विनोद भाई यतोहि भवन्तः मम परिचयः विस्तरेण दत्तम् अस्ति तदर्थं संस्कृत प्रचारार्थं मया एकः लघु संकल्पः कृतम् अस्ति यत् कदापि मंचतः किमपि वक्तुं भविष्यति तदा कानिचिन वाक्यानि फ्यू सेंटेंसेस संस्कृत भाषायाम् एव वदिष्यामि इतः मम संकल्पः अहम् अत्रापि एकः लघु प्रयासः करोमि I will make an attempt to speak in few sentences in Sanskrit. भवन्तः बोद्धुं प्रयासः कुर्वन्तु. You make an effort to understand what I am trying to say. संस्कृत एका अतीव सरला भाषा. भवन्तः बोद्धुं समर्थः भविष्यन्ति इति अहं मन्ये. I am sure you will be able to understand what I am trying to say. अस्मिन् वर्षे Gimacon 22 IMA वडोदरा शाखा द्वारा आयोजितः अस्ति. आयोजनः भव्यः अस्ति. अनेकानेक अभिनन्दनानि. अस्मिन् सम्मेलने भागम् अवगहन् सम्मानिनेभ्यः सर्वेभ्यः चिकित्सकेभ्यः नमः. आयोजकाः च वैज्ञानिक समिति प्रति धन्यवादाः प्रेषयामि यतोहि डॉक्टर वीसी पटेल मेमोरियल लेक्चर दातुं मम चयनं कृतम् अस्ति. माम् आहूतवान् अस्ति. अस्मिन् भव्ये सभागारे सर्वेषां स्वागतम् अस्ति. शुभ सायं सर्वेभ्यः नमः. I hope you could understand what I am trying to say. With the topic, it's right up. First slide. With the topic clinical and spiritual impact of sound that we are going to dwell upon in the next 20-25 minutes, it was only apt that the prologue was in Sanskrit, because it is the only language where apart from the meaning, the sound also has an impact. I'll give you an example. There are two eulogies, Stuti, Shiva Stuti, devoted to Lord Shiva. One is by Saint Tulsidas and another is by Ravan. I will recite few verses and I'm sure you will be able to make out who has created which. The first one, Namami Mishan Nirvana Rupam Vibhum Vyapakam Brahma Veda Swarupam Nijam Nirgunam Nirvikalpam Niriham Chidakash Makash Vasam Bhajeham. So this is the one. The other one, Jatativi Galajjala Pravaha Pavita Sthale Gale Velambelambitam Bhujangatunga Malikam Damat 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 Ninad Vad Maravayam Chakar Chandatandavam Tanotunah Shivam Shivam Jatakataha Sambrahma Brahmannilimpa Nirjari Vinod Vichivallari Virajamana Murdhani Dhagat 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 Jwala Lalat Pattapavake Kishore Chandra Shekhare Rati Pratikshamam Mama. I'm sure you would have by this time made out who wrote which, knowing the persona of Saint Tulsidas and Ravan. The first one obviously by Tulsidas, the second one was by Ravan. Now Sanskrit is a language where sound makes an impact. See, I am a cardiac surgeon and heart in Sanskrit or Hindi is called Hridaya. If you see the etymology, it is Hri plus Da plus Ya, Hridaya. Ya stands for Yati, means movement. So heart makes a movement. And what does it do while moving? Dadati. Dadati means gives. It gives nutrients and oxygen to the tissues, collects from the lungs, gives it to the tissues. And Hri means Harati. It removes what? Carbon dioxide, gives it to the lungs to send it out. And removes what? Toxic material, send it to the kidney to remove it out. So Hridaya is Harati, Dadati, Yati. As it moves, it does both the functions. So Sanskrit is a fantastic language, and I thought it was only apt that I use it in the prologue. See, sound is the way by which we are introduced. As Dr. Vinod Bhai said, Anil Jha has to come. So what is Anil Jha? Is a sound. That Anil Jha sound represents, I am represented by that sound. Sound makes an impact. We all know, it sets the right kind of ambience. When you go to a restaurant, to relax, there is a Indian classical or Western classical music running. You go to a gym, there is a different kind of music. You go to an aeroplane or a hotel lobby, there is another kind of music. So it gives a perfect ambience. Imagine a melodrama on TV. You turn on the TV, there is a melodrama going on, there is a lot of Rona Dhona and music, background music. Switch off, mute the TV. No background music, no sound, no 10-10-10, and the melodrama will lose 99% of its impact. So sound, and our scriptures have realized the importance of sound. They knew the immense potential of sound. And that's why in our scriptures it is written, Shabda Brahma, Nad Brahma. Shabda has been termed as Brahma. Next, please. The types of sound. I have made it anatomical classification, we all know. Ultrasound beyond 20,000. Audible sound, we all know, is 20 hertz to 20,000 hertz. And infrasound. I'll give you what infrasound is roughly about. All horror movies where they show spooky effect, where they give a scary effect, that great rumbling sound, that showing paranormal activity, that all is very close to infrasound. Infrasound is also used for discovering undersea oil deposits. All the earthquake activity, tsunami activity, those are all infrasound. When you have an earthquake, there is a deep rumbling effect beneath the earth's surface. That is very close to infrasound. Ballistocardiogram and seismocardiogram are infrasounds, use infrasound. Rhino, hippo, elephants, whale, octopus, pigeon, they all communicate using infrasound. So we are not able to hear that. Important thing is all these three types of sounds, they need a medium to travel. They cannot travel in vacuum. Next. The other type of sound which our ancient scriptures have mentioned, I call it physiological classification of sound, where there is a Baikhari sound. Baikhari is the audible sound which we are able to hear. Then another is Madhyama Parapashyanti, and a combination of the above. Madhyama sound is nothing but which comes out of your sense organs. The facial expressions, the emotion that you evoke, the emotions that you bring out. You can see the look of your boss. From the look of your boss itself, he may not say anything. He need not say anything. From the look of your boss, you can make out, he wants to tell you something. The affectionate look of a mother, the innocent look of a child, they all say a lot of things. That sound is called the Madhyama sound. Then is the Parapashyanti sound. When I visited Badrinath, many of you also must have gone there. Close to the Mana village, there is a Vyas cave and Ganesh Gufa and Vyas Gufa. It is said that Maharshi Vyas gave a dictation and Lord Ganesh was writing the dictation. But the caves are almost 500 meters apart. So I asked the tour guide, okay, how was Vyas, speaking very loud that Ganesh had to sit 500 meters away? He said, no, it was Parapashyanti Vani. It's just like a Bluetooth, It's just like a Bluetooth. You can convey or communicate what you want to say. Even during our freedom struggle, many of the yogis know, see, in that 20-30 years of period, 1920 to 1945, 47, there were, because of the effect of Parapashyanti Vani of Maharshi Arvind or Maharshi Raman. They were living a life of recluse. They were doing penance. They generated such a sound that it inspired elevated souls in our country to take part in the freedom struggle. Their Parapashyanti Vani created an environment. So very few people know that. So the important thing is, except the Baikari, rest of the three sounds, Madhyama, Para and Pashyanti, they all do not need any medium. They can easily traverse even in vacuum. Now, as far as clinical use of sound is concerned, when our scriptures said about mantra-guided missiles or mantra-guided weapons or mantra-guided arrows, the modern scientific community, called it a fake thing. They dubbed it imaginary. And they called it a figment of imagination. But over the last century, over the last 100 years, who could have imagined that a sound can produce an image of the body? Who could have imagined that a sound can cut and coagulate tissue? Who could have imagined that a sound can dissect into the tissues? So we have ultrasound now. Over the last 100 years, it is the best modality for imaging our body. The 2D echo, the 3D echo, the ultrasound for inflammation relief. It reduces inflammation. The HIFU, high intensity focused ultrasound, used for variety of tumors. The CUJA, cavitronic ultrasonic surgical aspirator for liver and brain surgeries. Venous and arterial Doppler study, the fetal abnormalities, shockwave lithotripsy. Shockwave lithotripsy is coming in a big way. It will make an impact in another 10-15 years. It will make a big impact. Harmonic scalpel, which we also use, ultrasonic cleaners, and seismocardiogram and ballistocardiogram. BCG and SCG, as I said, is not Bacille, Calmetta, Gurin, or Sydney cricket ground. It is bacillocardiogram. It's a measure of the recoil force of the body in reaction to the cardiac ejection of blood into the vasculature. And seismocardiogram is measure of the local thoracic vibrations produced by the heart contraction and ejection of blood from the ventricles into the vasculature. A lot of research is going on in European countries to diagnose coronary artery disease and left ventricle function non-invasively using ballistocardiogram and seismocardiogram. Both were heavily investigated in the last century, but with the advent of MRI and echo, they were largely abandoned. But of late, there has been a renewed interest. Next, please. Please look at me. So this is a small video which I will like to go very fast. It is a very simple procedure. We all coronary surgeons do is harvest the mammary artery, internal mammary artery. Through fast karo ne. Agar badho. Na. Video ma. What I wanted to show was the use of harmonic scalpel. उसमें है नहीं जाएगा. Anyway, forget about it. We go to the next slide. What I wanted to show is the use of how we harvest left internal mammary arteries in a skeletonized way using harmonic scalpel. So harmonic scalpel is a scalpel which uses sound to cut and coagulate vessels. Physical impact of sound, as I said, horror movies, sound creates an ambience. And nowadays, sonic and ultrasonic weapons have been developed to injure and incapacitate an opponent. It utilizes a focused beam of sound or ultrasound to cause, to give a jolt to the vestibulocochlear system. So it causes pain in the ears and a feeling of nausea and disorientation and too much of discomfort. So without harming the person, you can, have a control over the crowd. Next, please. So music and noise. Next, please. We all know what is music, how noise can hamper short-term stress leading to agitation, headache, tachycardia, and long-term causing tinnitus, can exacerbate cardiovascular disease, mental health, and can cause mental health and sleep disorders and stress, and learning disability in children. So what are the clinical benefits of music? It reduces blood pressure, respiratory rate, heart rate, reduces stress, elevates mood, social benefit is it brings people together during festivals, parties, weddings, and cognitive, reduces the effect of dementia, and also spiritual, it helps you connect with the divine. Next, please. So, can sounds be seen? Our rishis were called mantra drashta. Mantra drashta means those who can see sound. So, modern science has found out that yes, it can be seen, and that study is called the cymatic study. It is a study of visible sounds and vibration first discovered by Galileo, and Robert Hooke, the father of microbiology, also found peculiar nodal patterns when a floor was vibrating on a vibrating object. And Hans Jenny, he was a physician, Swiss physician, and a soil scientist. He coined the term cymatics. Next, please. So, what is cymatics? Next, please. It is nothing but, there is a plate kept upon a speaker which emits sound, and on that there is a vessel filled with water. Above that is a colorful light, and then the camera. Next, please. This system is called tonoscope. It shows the acoustic impact of sound. When a loose and light sand or lycopodium powder is placed over a plate and it is made to vibrate, the powder vibrates, it bounces on the plate and settles at nodal points where there is no movement, thus producing an intricate pattern which are called Chladni figures. So you can visualize sound. Next, please. In his research, Jenny noticed that when vowels of Sanskrit were pronounced, the sand took the shape of the written symbol for these vowels. When you say A and you vibrate that plate with A comes written on the plate. So interestingly, just like a vibration can lead to a geometric figure, the reverse is also possible. When a person looks at a geometrical pattern, it manifests vibrations in the mind of the observer. This is what we call as yantra in our scriptures. Next, please. So this is the cymatics of Om, which is, people say, is very similar to Sri Yantra. Next, please. Can you run this? This is the chanting of Om, which creates a vibration, the cymatic effect. Can you have sound? I'm sorry, there is a big problem with, anyway, forget about it. Go ahead, please. So it was a very interesting video where it creates, when there is a vibration, through sound current. There is chanting of Om, and see the vibration pattern happening in these are Chladni figures. Okay, next slide, please. So, as our body is made up of 70% water, Hans Jenny, he thought that the sound also can produce an effect on our physical body. It can produce an effect on our subtle body, on our mind. So, he said that you can look at the disease as a form of disharmony. And there is no organ system in the body that is not affected by sound. And human body being more than 70% water and water being a strong conductor of sound, sound can assist dissonance, which is disease, into a pattern of natural coherence. Your body has to be in coherence, to be disease free. Next, please. So two sound patterns which have been studied very widely are Om and the Gayatri mantra. What is mantra? Mantra is, manana trayate, which saves you from all apprehensions. And chanda means ya achadati, which covers you, which encircles you, which protects you. So the energy of these sounds help transform the chanter and elevate him to a higher level of consciousness. Next, please. So God is symbolically represented as a divine light or divine sound. And the scientists also believe that the initial spark of creation came from that sound, which is called Om, the universal syllable, the cosmic energy. And both Vedas and the scientists, they say that it was the Big Bang. It is the sound by which the universe was created. And everything has come from that one. Next, please. Which is in quantum physics called as unified field. From one field, everything has emerged, and that is the Om. Astrophysicists consider Om to be the sound of the universe. It is the cosmic vibration or vibration of the pure consciousness. Every place and person has a vibration. You all have vibration. We all have vibration. When you go meet a person whose frequency is matching with you, you feel better with that person. There are places which have vibration. You go to a pilgrim site, pilgrimage place, a tirth sthal, you have a different kind of vibration. You go to a place where mass murder has taken place, or go to a jail, there is a negative vibration. So every place, every person has a vibration. The cosmos, the nature also has a vibration which we call Om. So chanting Om, brings us in resonance with nature, and that is what we feel stress-free and peace and tranquility. Next, please. Pranav. Om is also called Pranav. Pranav means Pran ka Vapuh. What is Pran? Pran is vital energy. Vapuh means reservoir, an ocean. Time frequency analysis has concluded that steadiness of the mind is achieved by chanting Om. And sound of the sun is also a low pulsing hum. It's a hum, as described by the solar and heliospheric observatory data. Next, please. So this is the paper which was published where chanting Om, how it reduces stress. Next, please. So, important article was there in American Journal of Respiratory Care, where it says that humming increases the generation of nitric oxide in the body. And we all know how important nitric oxide is. It's a mediator and regulator of numerous processes, cardiovascular, immune, and CNS processes. It helps reduce stress and induces calmness. It reduces your heart rate, your blood pressure, and releases the hormone oxytocin. Next, please. So, Bible, see, Sikhism says, Ek Omkar Satnam. In Gita also, Lord Krishna says, Omkar Osmi. In Bible, in John 1:1, in the beginning was the Word was with God, and the Word was God. So, there is a lot of similarity. Chanting Om aligns you with the whole. It purifies your energy aura, which we call Kirlian photography, Kirlian aura, improves immunity and self-healing, makes you calmer, happier, and mentally healthy. So Om is basically Amen for Christians and Amin for Islam, and Hum, Om Mani Padme Hum, they say in Buddhism. They have their roots in this word Om. So our body, next please. Our body in ancient scriptures is called Gatra Veena. Gatra Veena means our body is a Veena. It's a instrument, Veena instrument. And as Veena has strings, we also have strings, which you can call the spinal cord is one string, and the two sympathetic chains on either side are the two other strings. And as Veena has nodes, we have all these chakras, which is roughly correlated with the plexuses. Next, please. So the Mooladhara is something correlates with the pelvic plexus, Swadhisthana chakra with sacral plexus, and the various plexuses. The Agya chakra with pineal pituitary axis, and the energy of this mantra helps in the generation of virtues through these plexuses, which is written on the left hand side. Mooladhara chakra keeps us grounded, Swadhisthana chakra makes you creative, generates emotion, Manipur chakra gives you the willpower, Anahat chakra gives you compassion, all these things. And Sahasrara chakra is the wisdom, Sahasrara chakra, which helps you connect with the higher consciousness. Next, please. So it is the original sound, Om is the original sound of the creation, and it is interesting to note that astrophysicists have now detected echoes of the Big Bang, and they have found it very similar to the humming sound Om. Next, please. So these are the 5 sheaths of the body. Because of paucity of time, I will not go into detail of that. But the thing is, Annamaya Kosh, we all know, is the physical body which we all treat. But there is another body which is called the vital body or the Pranamaya Kosh. Two similar healthy people looking healthy. One is lethargic and another is bubbling with energy. What is the difference between the two? They both are healthy. All parameters are equal for both of them. But one is bubbling with energy and the other is, doesn't want to work, is lethargic and lazy. The difference is the prana or the vital force in them. So that vitality is also increases with Om. And the mind, that is the Manomaya Kosh, and Vijnanamaya Kosh is the discerning mind. You know what is right and what is wrong. You make your discerning mind stronger by chanting Om. Next, please. So when Om resonates in all the four sheaths, you become purified and unified with that pure and all-pervading consciousness. You also would note that Om is also the sound of the gong. તમે મંદિરમાં જાઓ તો ઘંટ વાગે ને that sound is also very similar to Om, as well as the shankh, the conch. When you blow the shankh, it generates a sound which is also very and there have been several German experiments which they have found that several microbes are killed when you blow a shankh. Next, please. This is, for short of time, I think I would skip this. Next, please. So, mantra-based meditation. John Paul Banque, in a paper in EEG and neurophysiology, found predominantly slow alpha waves mixed with delta waves suggestive of relaxed state. And Dr. Selvamurthy, in his paper, Physiological Effects of Mantra on Mind and Body, which was presented at IIT Delhi, found that there is a reduction in blood pressure, heart rate, and galvanic skin resistance, suggestive of parasympathetic response, suggestive of relaxation. So next, please. And the other is Gayatri Mantra. Dr. R.S. Sharma, who is a cardiologist, he studied and presented a paper in API in Guwahati, showing the therapeutic benefits of Gayatri Mantra, of chanting Gayatri Mantra, and he termed it vocal medicine. He also studied the effect of this mantra on patients with paroxysmal atrial tachycardia and atrial fibrillation and found that the frequency and duration reduced. He also found out in a study over a period of 5 years that those who chanted Gayatri Mantra had a lower incidence of cerebrovascular and ischemic heart disease. Next, please. So this was the paper. Next, please. So the sound of mantra, it creates a positive impact on the physical body and the mind and the causal body. And mantras are in Sanskrit. As I said initially, that this is the only language where it is not only the meaning, but the vibration of the sound also creates an impact. There are several mantras which have a similar meaning to Gayatri Mantra, but the impact of the sound of Gayatri Mantra is exceptional, and hence it is called the crown mantra. Next, please. So there was a scientific analysis of mantra-based meditation and its benefit by Dudeja, professor and director of MIT University, and he also found that correct frequency of mantra sound along with correct intent oxygenates the brain, reduces the heart rate, blood pressure, and cures many ailments. Next, please. So my personal experience has also been similar. We have Vedic chants in our theater, operation theater, Vedic chants in our ICCU and waiting hall and in our hospital. We also have a place where yagna is performed, where oblations of ghee and havan samagri is given using Gayatri Mantra, and the relatives of the patient participate. And they have given me a very positive feedback. Yagna fire is supposed to potentiate the effect of mantra, and hence, yagna is associated, it's an inseparable element of every sanskar, be it marriage sanskar or namkaran sanskar or, graha pravesh sanskar or even funeral. Yagna is an inseparable element, indispensable element. On a personal level too, I have experienced tremendous benefits. Nikola Tesla, a renowned scientist and Nobel Prize winner, he said, if you want to find the secrets of the universe, think in terms of energy, think in terms of frequency, think in terms of vibration. Next, please. Conclusion, sound has tremendous effect on physical body. It cures mental and physical ailments. It it improves your thought process. And more research need to be done to validate our ancient wisdom about science and mantra. Next, please. When Isaac Newton was hailed as a great scientist, he said, "For you all, I am a great scientist, but to myself, I am only a child playing on the beach while vast ocean of truth lies undiscovered in front of me." Thank you very much.
Thank you very much, sir. It was a wonderful lecture, really justifying for which we have been honored. Thank you very much, sir.
Thank you.
Now it's a time for another great honor from the IMA GSB. Here I will take the opportunity to say something about P.R. Trivedi first. Dr. Prana R. Trivedi was born in Saurashtra in 1905, had medical education in 1928 from the Hyderabad and Sindh area. He also served during the Second World War to the army. He settled in Ahmedabad then having a 12-year services in the municipal corporation and then started the private practice. Actually, he was a founder, a root worker, used to move from door to door and hospital to hospital and enroll many members and contributed a lot to strengthen the IMA. It was rightly said, not only in Gujarat, but also at all India level, he is IMA walking on two legs. Members to start the All India Medical Licensed Associations along with the late Dr. Jamian Ram Desai. He was the Honorary Secretary in Gujarat State Branch for a number of the years. President of the IMA GSB during 1954 and 55. He was elected as a Vice President in First World Conference in Canada in 1970. He was awarded as a B.C. Roy National Award for 1976. So it's my immense pleasure to announce the name for this year's Dr. P.R. Trivedi oration to Dr. Ashok Shroff sir for the year 2022. And I request Dr. Bhupendra Bhai to give short brief about sir.
Welcome Dr. Ashok Bhai Shroff. He is a senior ophthalmic surgeon at Navsari, born 5th March 1949, done MBBS, Diploma Ophthalmology, MS Ophthalmology from BJ Medical College, Chief Ophthalmic Surgeon, Shroff Eye Hospital, Navsari, Consultant Ophthalmic Surgeon, Rudra Eye Clinic, Western Corridor, Adajan, Surat. He is also Director Consultant Ophthalmic Surgeon, Spectrum Advanced Eye Care, Surat. Past President, All Gujarat Ophthalmological Society 2012-13. Vice President, Indian Red Cross Society, Navsari Branch, Navsari. Member, Navsari Medical Association, All India Ophthalmic Society, American Society of Cataract and Refractive Society, American Academy of Ophthalmology, All Gujarat Ophthalmology Society of India. He gets so many awards: Gold Medal, Hariom Ashram, Surat 1980, Group Study Exchange Program, Rotary International, visited West Virginia, USA in 1978, Outstanding Personalities of the Year 1984 by JC Club of Navsari, Dr. Ganatra Rotating Trophy of Ophthalmologist 1999-2000 by GSB IMA, Gujarat State, won several Best Paper Awards, IRSI Gold Medal in 2018 for excellent work in ophthalmology, Appreciation Award, Expert Conclave 2018 by Epsilon, Felicitation Award in AOC Con 2019, Felicitated Award by All Gujarat Ophthalmic Society, May 2022. He has also visited following countries for meeting, workshop and presented papers in USA 32 times. He also visited West Germany, UK, Italy, Spain, Malaysia and China and presented so many posters and papers. Presented more than 500 papers poster at state, national and international conference. Conducted instruction course at AIOs and APO meeting. Offered service as a moderator, evaluated judge in many scientific meetings. He also designed 40 switchable scleral fixated IOLs presently marketed by IOC Baroda. He also designed illuminated chopper for safe phacoemulsification in cases with corneal opacity. Established blue light blocking properties of yellow natural IOLs, Alcon, in human beings. Provided training in phacoemulsification to about 91 new and practicing eye surgeons over last year.
last 10 years. Thursday scheme, all kinds of the eye care management is done free on every Thursday since 1989. JP Shroff Charitable Trust conducting outdoor camps in rural area about 70 kilometers away from the baseline hospital in Navsari since 19 years. Patient needing surgical management are brought to base hospital. Ankit Charitable Trust life-saving activities are done at Girafall, Taluko Vagai Dang to prevent and save unnatural deaths of visitors since 2006. So big hands to Dr. Ashok Shroff.
Thank you, Bhuvendrabhi. Welcome, Dr. Ashok Shroff, sir. So the branch of ophthalmology has been revolutionized significantly in recent past. So being a very specialized branch, sir will try to cover all the interesting recent advances in ophthalmology. Thank you, sir. Please. Thank you. Yeah, please.
Good evening, everybody. At the outset, I would like to thank Gujarat State Branch of IMA, its team, and the Baroda Medical Association team for having me invited here for this prestigious presentation. Then it was told to me that I have to give this oration in ophthalmology, and any subject in ophthalmology. I thought how many would be interested, because suppose we talk on cataract or any specialized subject, probably it won't penetrate your mind and it will go all about the head, get bored. In that case, then I thought, and I discussed with a couple of my friends, that if I talk about wavefront technology, if I talk about artificial intelligence, if I talk about other new things now, so that would be probably more interesting, and casually touching general topics which are very known to you, like cataract, glaucoma, etc. And I'm very fortunate and honored that this oration has been awarded. It is already been told by the speaker there. Dr. Trivedi has been introduced, gala person. So the more important is nowadays the blue light. The screen time has increased a lot. So I thought it would be better to talk something about blue light and effect on the eye. Then this refractive error, particularly the myopia, where the children have started using the glasses, very high number, and what can be done for them. Then there is the wavefront, as I mentioned, cataract, the recent concept. Then the lenses, let me tell you here, there is no lens equivalent to our crystalline lens. No lens. Till date, no lens has been found. The corneal transplantation, glaucoma part, the role of vitamin D, and particularly 3. It is very, I like it very much, and I've been practicing in my area since almost more than 10 years now. Then the medical and surgical management of retina disorders, as I told you, artificial intelligence, then this bionic eye, and the smart goggles, glasses. This is the future. For those very unfortunate people, those who are really, really blind. So then I was thinking about it, but see, these are the instruments that I have calculated. The cost of all these equipments, if you want to have, it is more than 5.7 CR. And there is only a very small eye, very small eye, very small eye. But then I thought the good thing is all equipments are equally good for both the eyes. The human eye, as you see here, is a cornea front part, just to recapitulate your anatomy. The cornea, the iris, pupil, and the lens, and there is a macula, retina part. This is the eyeball. So in next few minutes, suppose I talk about retina, I talk about macula, you will be able to understand, okay, where is the macula. COVID-19 it was a very bad time for everybody. And during this lockdown, almost everybody was confined to their homes, maximum use of cell phones, tablets, iPads, laptops, the screen time. And once that part was over, the education they've started, or even the office going, it was all offline. But during this period of about 1.5 to 2 years, the children, they've grown up by 1 to 1.5 years. And there was a change in the refractive error, because when we go a little later, I'll tell you, this myopia, the refractive error changes with the age. The age advances, the refractive error becomes more. Then during that time, when they started going to the school, they complained of poor vision more in the classroom. And the parents have started blaming that because of this constant exposure to the cell phone, they have spoiled their eyes. But it's not so. Now, what is blue light? It's a spectrum of light. The senior people must have heard when they were in the Gujarati medium, Jani Wali Pinara or Vibgyor. So this is a spectrum of light. This is ultraviolet light, which is not visible. But this part, blue light, which I'm going to talk, is very, very important. And fortunately, there are two components, the bad light and the good light. Between 400 to 420, it is bad light. If you are constantly exposed to it, it will spoil your retina. It's good light, though there is no need, you should not get exposed for a long time. But however, it will help you to get you sleep. It helps the circadian rhythm. And there are natural filters, the corneal lens and the macular pigment. Even the blue light goes there, there are luteins there, the macular pigment will absorb and keep your retina healthy. Excessive use of cell phones, laptops, it gives you more exposure. You are more exposed to the blue light. It will be harmful. It will damage your macula. And moreover, it will cause eye strain, fatigue, burning sensation. But as I told you, the good part of blue light, it helps in the circadian rhythm. Now you can see here, this is very important. Even if you have refractive error, then please make sure that you use glasses with the blue light blockers. You can see here the blue light is passed through this lens, but here, see, the blue light is blocked partly. You cannot see. And here the blue light goes all the way. But there, you can see the blue light is blocked. So you should have to have this type of glasses. Must insist with the optician. And not only that, if you don't have the glasses, but if your screen time is more, please make sure that when you are exposed to the screens, you must use plano glasses with the blue light blockers. The circadian rhythm, many must have heard about it. And it's a body clock, biological clock, for which the Nobel Prize was awarded in 2017 to these three scientists. Now, this circadian rhythm, when the light falls on the retinal ganglion cells, they contain melanosporin cells, which are sensitive to high peak in the blue spectrum. From here, through the optic nerve, they go to the suprachiasmatic nucleus. They they stimulate the pineal body, which secretes the melatonin secretion. This is an enzyme which is more, if there is more light, less melatonin, and you are active in daytime. When there is a less light, evening or the night time, the secretion of melatonin increases, and which will induce sleep. And in old age, because of the crystalline lens becomes yellow, the blue light transmission reduces, so you get less sleep. Then, as I told you, refractive errors. There are three main: myopia, hyperopia, means myopia means minus numbers, hyperopia means plus numbers, and there is a combination, cross numbers, astigmatism. Now this uncontrolled, suppose you don't use the glasses, then of course there is a poor vision. But along with that, you have an eye strain and the headache, and particularly more with the astigmatism. Now the refractive errors, myopia is very important. Very, very important. You can see here, here is a normal eye, but here the rays meet in front of the retina. So you have to have a minus lens, concave. So that will take the rays right to focus on the macula, retina. This is on rise. Unfortunately, it is on rise. More need. See, there is a rise. Even before that, 15, 20 years, 25 years, there were myopics, but they did not need the glasses because working area was small, the vision requirement was small, less. So now it is a more need, and more so in the IVF children. Now, myopia is a direct relation with the age. Because age increases, the height and the weight also increases, and the myopia will increase. The range is -half, and highest is -30. But it is mentioned here, but I have seen -54. -54. But treatment is medical and surgical. Rather than medical, it's a preventive. This is very important. You must remember this. The use of atropine diluted 0.01%. We have been doing this study since almost 3 years now, and these papers were accepted in the ACRS in US. What we have seen is 236 children were under this treatment and regular follow-ups. Mean height increased by 5.63 centimeter, and mean weight gain was 3.76 kilogram, and the length of the eyeball increased by 0.22. It is all mean, but there was hardly any change in the refractive error because of the use of these drugs. So in your practice, suppose you come across, or even in your family, this child has a myopia, is using minus glasses, better please consult some eye surgeon. Recently, of late, all these high number glasses, myopic plus glasses, there is a trend that we don't want any glasses, and particularly more in the youngsters. Now there is a job requirement also. In our area on Valsad side, South Gujarat, there are many people staying in the offshore, near the shores, Tandils. They usually go for the job to the merchant navy or any, I'm just quoting an example. So their requirement is no glasses, and vision should be 6/6 normal in both the eyes. So, and on medical ground, suppose one eye is normal, the other eye is -5, -6. These patients cannot use glasses. Either they have to use contact lens, or in that case, that eye having -5, that can be treated surgically. And what are the types of surgery? That you can have laser refractive surgery. Everybody knows about it now. The LASIK, the femto-LASIK with a smile, and then if your number is very high, more than 10, 15, then you can use the implantable contact lens or the lens extraction. This is now no more. Earlier we used to do that. We have done many. The LASIK is very popular here. You can see that the flap is made here. The flap is made here like this, and then you can see that is auto running? Is auto running? There is no. There is auto running. The slides change of its own within few seconds. It is not so. But there is a timer there. निकल जाता है मेरा ऐसा नहीं था टाइमर है क्या नहीं हो जाता है मैंने सब 2-3 बार चेक किया था ठीक है अभी प्लीज दिस इज क्या करते हो ओनली ऑन क्लिक This should be okay. Thank you. So it is most popular. The treatment you can have -5, -half. We have treated with -half. and up to 8 to 9. But this is very important. Make sure that it should not harm the patient. You can see here in this video, the flap is created like this, and then the laser will be given here like this. It takes few seconds, and it is all done under topical anesthesia, just Gimacon drops, no injection, nothing. You can see here some laser running here, and once it is done, after few seconds, and then the flap is put back like this. That's all. The vision is corrected. There is another procedure of late which has come, SMILE. Of course, it is very recent technique, very expensive. But however, here the lenticular is made. Lenticular is made. You can see that there is one automation. You can see that the laser is given in the front portion and then the back portion in between, and the lenticular is created, and that through the small incision, this lenticle will be taken out. See the difference between this and the earlier one, it was a big flap. Here it is a very small incision, And then here, this is the recent technique, but very expensive. But the overall patient's compliance is very good. Then when the myopia is very high, where the LASIK is not advisable, you can see that when -10 and more, it is, you can see here, it's a clear lens, normal eye, but through the very small incision, the lens is inserted into the You can see that the lens is inserted between the iris and the clear lens. This goes here. It is a 40 micron. The thickness is 40 micron, and they are negative lenses. And there is no adverse effect on the cornea. The most important part, the cataract. I mean, everybody is familiar with them. Most of, maybe might of you here have undergone cataract surgery. It is the most common cause of visual impairment, and it is found in now in young patients, 30, 35 years. I have operated. See, this is auto. There's something wrong. It is even young patients. Now, why they need? Because they are doing job, maybe marketing, they have to move around, and they find it difficult during night. The timing becomes difficult. So it's now need-based surgery. See, need. If you have a need, if your normal life is disturbed, you can go for a cataract. If there is a cataract, even 10%, you can go for it. Why? Because it has become safe and more advanced technique. Now, the another thing is, you can do it under topical, just put the drops. And newer implants, you can see this is a mature cataract, fully mature white, and it's a very small part of cataract at the back of the lens. Now, these patients need surgery. You can see here, earlier, long back of 10, 15 years back, you put the lens and doctor will be happy, patient will be happy, the vision has come to 6.6 without glasses. But a lot of problems because the lenses were of old type. They were non-spheric. So that would give you like glare, halos, you cannot see, you cannot drive. But with this modern technique, modern lenses, the use of aspheric lenses, you can see the images become so clear that not only daylight, but the night become good. Office work becomes smooth. Vehicle driving, TV viewing, computer, everything becomes so smooth. So these lenses now is very important. The intraocular lenses, there are many now, many innovations, many varieties. But the most important is proper counseling. Let me tell you, now our chair time is increased. Any patient comes, suppose we diagnose he is a patient has cataract. But the most important, but what is his daily routine? What he is doing? In which profession or a business he is involved? What is his work? This is very important. Must spend 2, 3, 4 weeks, spend few minutes, and then anyway, so we spend time and we try to find out what is his requirement and then what is his expectation. These two things are very important. There is nothing just cataract, solado, nikaldo, and then you put a lens. No, you must find out what is his requirement, what are his expectations, and then accordingly you select the lens and put the lens. And I tell you, even the multifocal lens, they are not ideal for everybody. Multifocal lens means you don't need any glasses, but still they are not ideal. You can see here the cataract surgery. This side is all animation, so you can understand better. This is the normal routine, what we do with the instrument, with the hand. क्या बताए नहीं होना चाहिए ना बहुत मैंने चेंज किया मैं तो देख के आया हूँ घर पे बहुत चेंज किया था You can see here it is made by with the help with the instrument. This is done by the laser, the incisions and everything by the laser, even the segments, and then the phaco is done. That part is same for both the cases, both type of surgery. And once it is done, you can put the appropriate lens and then okay. The corneal transplantation, I'll just touch very superficially. We know that there are different layers of cornea, and here there are new types of grafting which has come. Earlier used to be full thickness, means we remove the part of the cornea, the whole cornea, and put it from the eye bank or the eye donation bank. And then of late only the layers are removed. And accordingly from the donor's cornea, the eye donated cornea, we remove the same layer and put it here. And now of late, even the prosthetic cornea, artificial cornea have come. But they are indicated in very few patients. You can see here, this is opaque. And this bad part of the corneal endothelium, the part of cornea, not the whole cornea, is taken out, and then the same part, the part of the cornea taken from the donor cornea is put into the inserted here, and then it is flattened out, positioned, and then they become cornea. That part becomes clear, and the patients get good vision. I'm sorry about it. Auto changing. Here you can see, here the whole cornea is removed. It is grafted with the new cornea, and then this bad part of the cornea is taken out. Only the part, and then it is grafted here. The glaucoma, like blood pressure of the body, the high pressure of the eye, there are two types, Mitto-Jhammer and Kadwo-Jhammer. Mostly what people know, we know. This open angle glaucoma, you can see this is a normal flow of aqueous from the ciliary body. It goes out here to the pupil, it goes into the angle. And when the tension becomes more, it exerts pressure on the eyeball wall, and more so on the optic nerve. And once the optic nerve is damaged, it is damaged permanently. And of late, there are many things. Patients, this is the bad part. The God has given two eyes, so they come at very late stage. The one eye is already lost, but the other eye is normal. So they don't realize. And aim is to save the further damage. Many new drugs have come, surgeries become more important, more sophisticated, Newer implants, you can see here, the implants are here done. But it is all in intractable cases of glaucoma, where the normal surgery is not working. Here you can see that the lens has been, the valve has been implanted. Even the cardiac surgery valves, so we do have valves here. Now the valves are for different varieties. And what I've seen, that at times, because of the high pressure, the ganglion cells are affected and they undergo apoptosis. Even if your pressure has become normal, it remains normal. So in that case, usually I support with this B12. The wavefront technology, this is probably a new word. It measures the highest quality of vision. See, normally the light rays pass through the cornea, pupil, lens, they fall in the retina. Even in normal eye, many times they do not form the point focus. And vision is 6, but they fall away either in front or behind by microns. 100 microns, 200 microns, 50 microns. So they produce aberrations. They get glare, halos, and they increase with the age. The pupil diameter plays very important part. Wide pupil, vision disturbances is more. And the pupil size changes with the daylight and the night. The night it becomes large. Up to 6 millimeter is okay. But normal balance is 4 millimeter in Indian subjects. And you can see here with this light seen beautifully, clear cut, dot pinpoint, it becomes blurred when the pupil is dilated. Now, 20 minutes, 30, 30 minutes. The 10 minutes. Here, we have seen that, we go back. This is a normal fundus. This is right and the left. This is optic nerve head. From here, it goes to the brain, occipital cortex. And this is macula. This is artery, and this is the larger part is vein. Now this diabetic retinopathy here, see, you can see at times long-standing and uncontrolled diabetes. You can see that it produces damage to the capillaries and more so to the endothelial cells, very micro. Now that leads to the blood leakage. You can see here, the blood has started leaking. That produces hypoxia of the retina. And then just to meet the oxygen requirement, you can see that it is all getting worse. It has produced hypoxia and more so in the central part. This is macula, very important part of the eye. And that leads to, you can see here, that leads to neovascularization because the eye wants to supply the oxygen where there is a hypoxia. So the blood vessels they come up out of emergency. And so this is very bad, and that they bleed immediately, and they lead to neovascularization. Once the neovascularization goes on, it will produce fibrosis and the retinal detachment. Can I stop? Vinod bhai, do you want me to stop?
Sir, we are short of time, so.
No, but I'm given 30 minutes.
Okay, sir.
30 is not done. Timer was set at 20.
Sir, please continue, sir. Yes, sir.
Sorry? There is a medical management of the initial stage. The strict control of diabetes is very, very important. Retinal lasers are, of late, it has become very popular. Antioxidants, vitamin D3, and may stop further damage. Anti-VEGF injections have come up. And surgery, when there is it's beyond medical management, you can go for the surgery. And for the which is hemorrhage and cleaning the bands, we can use the gas or the silicone oil. You can see few pictures here. There is a vitreous hemorrhage with the bands, and after surgery, it has become clear with the silicone oil inside. It's a recent photograph, but of time, of late, when we remove the silicone oil, it becomes very good. The proliferative retinopathy after surgery, it has become very clear. It's a macular hole. You can see there is a hole here, and then after surgery, it has been filled up. IVF babies, they are on rise, particularly underweight, need oxygen therapy. So they lead to the development of retinopathy of prematurity. And then, but the regular checkup in NICU is very important. And intravenous injections have come, retinal lasers, you can see here, the starting point, then it goes further, and then the whole retina is scrambled up. The macular degeneration, just a few minutes, this is very important because this blue light, it affects here. It produces free radicals, and then it damages the macula. See, this is a normal picture of this thing on the room, and then it becomes blurry, then it becomes dark in the center, and then you find it's wavy. So this is retinal pigment epithelium. The fluid is collected here. This comes from the choroid. This is choroid, the outer layer. And then once you can see that it is a drusen. It's a dry type of macular degeneration. But then that produces neovascularization because of the vascular endothelial growth factor. And for this, the anti-VEGF injections are introduced into the eye. And you can see these are the anti-VEGF drugs, and they don't allow to further progress in neovascularization. And then what happens now? These, something wrong. You can see the hemorrhage, very bad. This is all hemorrhagic degeneration, and after injection of Avastin, it has improved. The only problem is you have to give multiple injections because it is a limited time effect. Vitamin D3 is very important. I love it. It has a very good anti-angiogenesis effect and the anti-inflammatory effect. This is a slide from a patient known to us. She was a central minister in the Indian government, and when she started developing this degeneration, she was put on the antioxidants and vitamin D3 particularly. Until she died, it continued the same without any problem. Artificial intelligence, it to accomplish the task by computer. It is useful in diseases which are common. Here what is done, the computer receives many images. We have to fit the computer, and then we have to build a model. And then once the new image comes, the machine will try to find out. However, it is not 100% accurate. You can see here, the image is taken on equipment, and then it is analyzed with the data, and then the diagnosis is made. The limitations are, the most important is, there is only one diagnosis. There is no difference of opinion. Maybe good for us. But limitations, it needs large data. And it is possible only for few diseases. Variations may be missed. This is a bionic eye, artificial eye, which is again useful for limited number of patients. There is a digital camera, and then it receives. But then in the eye, the silicone chip is implanted. It receives the image, and then it transforms into the electrical signals, which go to the optic nerve, and then the patient receives the image. And you can see with this eye, it is not exactly seen, but at least you can see the figures. This is the image with the bionic eye. Very expensive, nearly $100,000. And this is smart glasses. You can see that. There is no need to put the chip into the eye. They are the glasses. These electronic glasses use an HD camera. And these images are transmitted from the forward facing. Whichever is there in front of your camera, goes there with the two small screens here. And this is how it has the people, those who are visually handicapped. Friends, see, I tell you one thing. This vision is very important of spatial senses. Even the God has done what he has done. God has given out of 12 cranial nerves. 12 cranial nerves. The four nerves are directly going to the eye, and two through the lids and the muscles. So please, friends, is a pearl of our body. Please take care, utmost care. It is pearl. Thank you very much, sir. I'm sorry I have taken more time. I'm sorry.
Thank you very much, sir, for a wonderful presentation. Please be there during the inauguration program, which is followed shortly to receive the oration in presence of dignitaries. May I now request Dr. Tushar Patel to felicitate the today's chairperson, Dr. Bhupendra Bhai and Dr. Vinod Bhai.
घर पे देखा था, कुछ नहीं होता था, 2 बार देखा था, कुछ भी नहीं होता था, ऐसा कभी देखा नहीं, मैं कर देता, निकालो ये भी निकालो, कुछ तो गड़बड़ है यार यहाँ, मेरे को इसमें देना चाहिए था पहले.
Hello, I invite Dr.
Without wasting much time, within 5 minutes, we are starting the inauguration program, so please remain here. And meanwhile, there is a very important short clip will be displayed here, and it will be important to see and yes.
So, this is very important video, please see.